President Su of Taiwan, okay. Deputy Minister Tsai of Taiwan EPA, Assistant Administrator Nishida of the US EPA, Director General Wu, our distinguished guests, ladies and gentlemen, on-site and online, good morning. On behalf of the Ministry of the Health and Welfare, I would like to thank Taiwan EPA and the US EPA for hosting this session. And thanks all participants for joining us in this section on climate change and children's health. This year, COVID-19 pandemic continues to impact on global economy, trade and travel, and also forces put many events hold. However, we didn't hold back the Global Health and the Welfare Forum. Instead, we are speaking even louder than before for health. Besides the pandemics, Taiwan also confronted an unprecedented drop this year, just like the overwhelming flus we saw in several other countries, or due to the climate change. So therefore, we have invited many experts to navigate our view and enhance our awareness of the climate change and the children's health in this session. I hope this session not only bring attention to the relevant issues, but also share experience in addressing the problem through all of your engagement. EPA, Taiwan EPA and the US EPA have collaborated for more than 20 years in the field of environmental protection. Since the health impacts to vulnerable group population are our main focus in recent years. We, Ministry of Health and Welfare, officially joined the International Environmental Partnership Program, IEP, to further protect children's health. So this is the second year that we have held the parallel sections in our Global Health and Welfare Forum. Last year, we made pediatricians aware of the hazards of the air pollution. This year, we wanted to create an opportunities for international dialogue and experience sharing on the challenges of climate change. Taiwan is always willing and able to contribute globally and share our knowledge and the resources with our friends worldwide. So we also have received much support through vaccine donation from the United States, Japan, Lithuania, Czech Republic, and Slovakia during the pandemic. Taiwan appreciates your unwavering support, and we will keep working hand in hand with the international society in facing all the emerging global health challenges and impact. So to reinforce our determination, I would like to quote President Tsai's remark in her COVID-19 cooperation address. Taiwan can help. Taiwan is helping. Thanks for your participation. And the same goes for our friends online. Please enjoy this section. Thank you so much.
Thank you very much. 谢谢十四长. I think we'll continue to do whatever we can through the area that we have been able to collaborate with. So since this plenary session will very much be focusing on tackling the issues related to environment and health. And I think it's equally important to have the input from Taiwan's Environmental Protection Administration. Let's welcome Deputy Minister 蔡宏德蔡副署长，谢谢，谢谢。
Let's welcome Deputy Minister Hong De Tsai of Environmental Protection Administration.
Thank you, President Su, Deputy Minister Shi, and also DG Wu and Dr. Dong. And I think we have Nisida on the line, the Assistant Administrator Nisida. And distinguished guests, both here and online. Good morning. It's my honor to join the Ministry of the Health and Welfare and the US EPA in welcoming you to the Global Health and Welfare Forum in Taiwan, particularly this session on climate change and children's health. Like many countries around the world, Taiwan is facing the same challenges of climate change and extreme weather. Just a few months ago, we experienced the worst drought in 50 years. And then it was followed by heavy rainfall that caused great damage to the country. These disasters caused by climate change and extreme weather pose a threat to the stable supply of the basic necessities, such as food, water, and housing. And the health and the safety of the children are particularly affected. If we do not take bold action to address climate change, I believe we will witness more vulnerable groups suffer from effects of climate change in the future. Along with the international community, Taiwan addressed climate change by the legislation of the Greenhouse Gas Reduction and Management Act in 2015, setting the legal foundation to promote and implement carbon reduction and mitigation measures. In July this year, the Taiwan EPA established the Office of Climate Change. The main tasks of the office include amending the Greenhouse Gas Reduction and Management Act to the then will become Climate Change Response Act, right now only in draft, formulating a pathway to net zero carbon emission and setting up a carbon pricing mechanism. The office also aimed to strengthen public awareness and education on carbon reduction and integrated mitigation work among government agencies, so that the target of the carbon neutral may be reached by 2050. Given the global struggle with the COVID-19 pandemic, I'm deeply touched by everyone's attendance in today's event. I wanted to thank the Ministry of Health and Welfare for once again including these important topics in this forum. As we build up on last year's fruitful discussion, we look forward to more exchanges that will be even more comprehensive. Finally, I wish you a most successful session and a good health. Thank you very much.
Thank you very much, 副署长，谢谢。Last but definitely not the least speaker for our opening session, we will welcome Assistant Administrator from the US EPA Office of International and Tribal Affairs, Ms. Jen Nishida. She is definitely not a stranger to this forum, especially with a well-appreciated and much memorable a talk last year, which still plays a very, very strong impression on the audience, not only here, but I think throughout those who have been able to join last year. So I hope the virtual setting is ready. And so now we can invite
can we show Ms. Nishida on the screen?
Yes. Welcome.
Good morning.
Good morning.
And good evening.
Okay, the floor is yours now. Yes.
Can you hear me?
Yes, we can hear you.
We hear you very well.
Great. I am pleased to join you today to kick off this conversation on climate change and children's health. Today's session builds on the Children's Environmental Health Program that the US EPA and EPA Taiwan, as well as the Ministry of Health and Welfare, launched together in 2017. I would like to thank Vice Minister Xu and the team at the Ministry of Health and Welfare for hosting this year's Global Health and Welfare Forum and for being such an important partner to our Children's Environmental Health Program. I know this has been a very busy and difficult year for MOHW and the health community around the world as we try to beat back the global pandemic. I'm also grateful for Deputy Minister Tsai and the team at EPA Taiwan for their leadership and commitment to our partnership and with the ministry as well as other ministries. I know that Deputy Minister Tsai has been a longstanding friend and partner of US EPA, and we value his friendship. Finally, I would also like to thank the team at the American Institute in Taiwan and our speakers, Dr. Sheffield, Dr. Philipsborn, and Professor Lung, who I'm looking forward to hearing their presentations. As the climate COP in Glasgow begins this week, it is very timely that we are taking this opportunity to discuss the health risk to children and how we must work together to protect children's health. I want to recognize that Taiwan will be hosting a global environmental education partnership launch in Glasgow next week. I will have the honor of participating in that launch, which is another demonstration of Taiwan's leadership and commitment to the environment and to children's welfare. During his first days in office, President Biden issued a slate of executive orders that set clear priorities to protect public health, address the climate crisis, and deliver on environmental justice. I am proud that US EPA is at the heart of this agenda. Partnerships such as the International Environmental Partnership with Taiwan enables us to extend this conversation globally. And the Global Health and Welfare Forum enable us to build knowledge in the medical community, in the policy community, and in the child welfare community on the environmental health risks to children. In the United States, EPA works under the authority of a presidential executive order and the President's Task Force on Environmental Health Risk and Safety Risk to Children to explore issues that affect children. Our focus centers on children most at risk, children of color, children living in poverty and substandard housing, and children in rural and tribal areas with fewer basic services. We are committed to making progress on several critical climate and clean air issues. EPA is developing proposals to achieve ambitious reductions in climate and other health-harming pollutants, including in the oil and gas sector as well as in the transport sector. Our children's health training programs developed under IEP are essential tools to at the international level to raise awareness and responsiveness of healthcare providers to children's environmental health issues globally. EPA's Office of Children's Health Protection is helping to build awareness across the agency and across the US government about the unique vulnerabilities to children to environmental risk, including vulnerabilities to climate change. In the United States, like in Asia, we are experiencing more and more extreme weather events, including floods, wildfires, disease vectors, and other climate changes. And children are particularly vulnerable to the impact of these changes. That is why my colleague Martha Berger, who has joined us also today from our Office of Children's Health Protection, and others in the meeting today are working to raise awareness and build knowledge on how to take actions to address the climate risks to children's health. According to a UNICEF study, exposure to the effects of climate change during childhood can cause both immediate harm as well as cause damage later in life, and the direct impacts of extreme weather events such as floods, droughts, and heat waves can lead to adverse health outcomes, ranging from physical injuries from drowning or heat distress, respiratory diseases, and population displacement. Climate change also affects food production and increases the risk of malnutrition and affects access to safe drinking water. The UNICEF study found that with each of these health outcomes, children have increased vulnerability compared to the rest of the population, and they are one of the groups most likely to experience adverse health impacts caused by climate change. For example, child development is affected by malnutrition, and children are more susceptible to food and waterborne diseases, as well as vector-borne diseases resulting from climate change. Within the last decade, the World Health Organization estimated that 1.7 million deaths among children under 5 were attributable to the environment. Reducing environmental risk could prevent 1 in 4 children's deaths. Therefore, our work is most urgent. US EPA is committed to working with our partners in Taiwan and other partners around the world to both build knowledge and capacity to address the climate risk to our children. 谢谢, and I wish you a successful conference.
Even another wide range of potential collaborative possibilities on both sides. And I believe with the continued success of this platform, when we return in the coming years, we'll be able to exchange further in terms of how we are able to effectively improve the environmental quality and how that will relate and contribute to betterment of our children's health. So once again, thank you for restating the commitment from US EPA and on behalf of my colleague and the people here, I think we will do just the same. Thank you again. I think they will conclude the opening session.
Yes, with a group photo. So
right,
for that, we would like to invite President Su back to your seats. Our photographer will be taking a photo of all of you from the stage. 那接下来是我们大合照的时间呢，我们请摄影师呢到舞台上面帮大家呢一起拍一张照片哦。Jane, we are sorry you couldn't be here. We're going to do a photo. We promise you we're going to Photoshop you into the photo and send it back to you later. OK， 所以请大家呢看向我们舞台上大会摄影师的镜头。OK， 3, 2, 1. Let's do one more. 再一张照片。OK， 比一个赞好了。Yes, everybody thumbs up. 3, 2, 1. All right, thank you very much. Okay, so moving on to the first keynote talk to introduce our speaker, back to our moderator, Professor Su. Yeah, here. Please.
Okay, can I sit? Okay, let me make sure that Dr. Sheffield is now online already. Is she? Perry?
Yes, I'm here.
Oh, great. Wonderful. This is Jenny. My name is Jenny Su, and I used to spend some time in Boston, so welcome. So let me make it formal. The first speaker for this plenary session will be Dr. Perry Sheffield, and she has a wonderful and most beautiful record in the area of environmental science study, and later move on to complete her medical doctor education and training throughout her career. She has done research both in the States and in other country, including Puerto Rico and the other of islands. I think with that, she has the most holistic and further understanding toward how the environmental health should be visited, should be understood, and should be orchestrated from a sort of regional and cross-country perspective. So with that, Dr. Sheffield, the time and flow is yours. Thank you. You got it? Did she hear
Hi there.
you?
Good.
Okay, good. Okay.
Good morning and good evening. I am Perry Sheffield, and I'm very pleased to be given the opportunity to speak with you all today more about children's health and equity in a changing climate. I work with the Pediatric Environmental Health Specialty Unit Network under the American Academy of Pediatrics, and we're funded partly by the Centers for Disease Control and the US EPA. I hope after hearing today's presentation, you will be able to also demonstrate the unequal impacts of climate change on children and discuss ways to think about these issues considering equity. So here you see two covers of the medical journal, The Lancet, which declared climate change on the left, the biggest global health threat to the 21st century, and on the right, the biggest opportunity of the 21st century. It is both. And as we gather for this Global Health and Welfare Forum in Taiwan, simultaneously, the almost 200 member states of the United Nations are in Glasgow for the Conference of the Parties, or the COP26. And today we're going to talk about why meetings like that are so important for human health, particularly children. I'm going to talk about those health effects, and this slide, which you may have seen, was created by our Centers for Disease Control and Prevention, illustrates how the changing climate, which is seen here in the very middle of this circle, those rising temperatures, the increasing carbon dioxide levels, extreme weather, rising sea levels, translate into that next circle where you see the changing in exposures, vectors like mosquitoes or ticks, allergens like pollen, or water quality changes like E. coli contamination. And now those things translate into the health impacts or the outcomes seen in the outermost shapes here, like asthma or malaria or malnutrition, heart attacks or stroke, or mental health impacts. So I want to open with a story about a boy named Kali. He's 11. He's growing up in a coastal city in the United States, and he attends school. He helps his family. He lives with his mother, and he lives with his grandfather. His family immigrated from Vietnam when he was a boy, and his father had died before he came. His grandfather is vision impaired or blind and does not speak English well. And Kali, even at 11, is starting to help his grandfather. He helps him get to appointments. He helps with translation when his mother is working. In mid-September, a tropical storm makes its way up the eastern coast of the United States, and it causes flooding on the first floor of their apartment and a power outage that prevents the air conditioner from being used. And the days after the storm are very hot. Kali's school was also flooded, and so for an entire week after the storm, the school is closed while it's being repaired. But Kali's mother has to return to work. She's a health aide. So Kali is at home with his grandfather. I want us to consider some of the potential risks. There is debris on the sidewalks outside that makes walking more dangerous, particularly for the grandfather who's vision impaired. There's mold that grows quickly in the home when it's warm and it's wet. They weren't able to dry it out quickly. And Kali, who has asthma, has an asthma exacerbation or an asthma attack. Because of the hot weather, but the no air conditioning right after the storm, the grandfather actually gets dehydrated and has to go to the emergency room for IV fluids to get rehydrated. The mother also notices as she's coming home in the evenings from her work that she sees more mosquitoes out because there's more standing water, more places for them to breed. And they also hear about a neighbor who was diagnosed with West Nile virus. In this part of the United States, there's not malaria and there's not Zika, but there is West Nile virus. I also want to note that this family qualifies for some federal flood insurance money because of the damage that happened to their apartment. But to get that money, they have to either file online, which they can't do right now because they don't have internet, or the mom would have to take time off from work to go to the local support center, and she can't do that right now. So all of these and more are risks that are intensified because of the changing climate. We know that without strong, rapid, sustained reductions in heat trapping gas emissions from burning fossil fuels, it's estimated that an additional 250,000 people will die per year from climate-related causes between the 2030s and the 2050s. But we also know that some people are more sensitive to the changing climate. That's pregnant women or still developing fetuses, children, or people who have other illnesses. And some people have more social and structural barriers to health. I want to show you one report to illustrate this. This is a graphic from a US EPA report on social vulnerability to climate change. It shows how groups such as those that are low income, ethnic or racial minorities, or those who have lower education are more exposed to the things shown in these different color bars, like changes in air quality that affect asthma, extreme temperatures for people, particularly for workers who are exposed to the weather, worse traffic even, or property damage from coastal flooding or inland flooding. And we can see in this fairly sterile report how many things in common it has with that story that I told you of Kali's family. But at the heart of this, the crux of the climate human health problem is a social injustice. We know that those who have contributed least to the problem will suffer the most, and that's illustrated in this graphic with these two world maps. The one on the top shows the countries distorted by their relative contribution to global emissions. The one on the bottom shows the countries distorted by their projected impact or mortality per million population. And we can see that it's almost opposite countries in terms of who's contributed the most to who will be affected the most. But part of the reason I went into pediatrics is because children are amazing creatures. I have had patients during my career as small as will fit in the palm of my hand and as big as 3 times my size. But it is this wonder of their rapid growth and their development that also creates what we call in environmental health windows of vulnerability. Here we see some examples of how climate change affects these windows of vulnerability, and it can harm children who are even still developing through things like extreme heat affecting, causing outcomes like lower birth weights, all the way up through adolescence, where we know that teenagers are more likely to suffer mental health impacts from extreme weather or negative impacts when they're trying to do sports as teenagers, for example, and many other things. But one of the things that I want to emphasize from this talk is that by and large, climate change makes existing problems worse. There are some new problems that climate change creates, but most of it is that it makes existing problems worse. And so I wanted to show this map, which many of you are probably familiar with, which shows the burden of under 5-year-old mortality per 1,000 live births globally. And we see, when we look at it this way, in this color-coded map, the areas that are red are those that are most affected. And so I have the greatest burden on already, without climate change, on child health. But this is true also in high-income countries. Some children and families are more at risk because of inequitable history, ongoing racism, and other inequitable policies. And studies like this one that was highlighted in the New York Times newspaper further illustrate these unequal impacts. This one talked about how Black mothers are most at risk of pregnancy complications related to climate change. And as we saw, so in addition to race and ethnicity and gender, lower education status, less resourced economic status can also worsen their risk. And so we know that many families have intersecting risk across these different identities and situations. It is not because of some biologic condition of race. Race is not a biologic condition or ethnicity, but it is because of the structural or systemic factors that ultimately drive the health differences that we see across different populations. And we see that play out globally. It is estimated that over 80% of the global burden of death as well as disease will impact children, particularly the youngest children. And in many ways, climate change acts like as if you were shining an ultraviolet light on minerals. That's what we see in this picture. Minerals that don't change when you they don't change in their chemical composition when you shine the light of certain wavelength on them, but you see them in different ways. Climate change or other disasters like the global pandemic, the COVID-19 pandemic, has illuminated or aggravated certain problems so that we can see them more distinctly, more jarringly. It is what some people refer to as a neon effect of disasters, and climate change acts that way. So how do we begin to think about this with this equity lens? What is the story? We have an imperative to tell the story, both of the data and the people. Dr. Rebecca Phillips-Thorne, who you'll hear from next, and I had the pleasure of co-authoring this article with a high school student. And I wanted to highlight this to illustrate how we are trying to tell the story and also trying to involve leaders that are already emerging, but trying to learn from them, as we were doing from this much younger Latinx high school student from Pennsylvania. And we wrote, to support child health, pediatric providers must recognize the environmental health harms posed to children and multiplied by climate change, as well as identify opportunities to center the voices of families and communities to dismantle those inequities. And we're trying to do that through networks like the pediatric environmental health specialty units that I mentioned that are across the country. And our goal is to bring environmental health into children's healthcare. But we're doubling down now and really trying to think about how to do that and mitigate the impacts of climate change and thinking about structural racism and other inequities that are perpetuating those health disparities that we see. I also think that initiatives like this one that's come out of the International Environmental Partnership with a combined effort of the EPA Taiwan, the Taiwan Health Promotion Administration, and the US EPA, where they are working together to develop these trainings for pediatricians that focus not just on the environmental part of it, the air quality, but also thinking about it as an equity problem. They're educating the environmental experts about the health part. They're educating the health experts about the environment part and the linkages between those. And if you're interested in more about these trainings that are just coming out, I encourage you to reach out to some of the collaborators through the EPA Taiwan, the Ministry of Health and Welfare, or even Battelle, the group that is helping to develop these modules. So we think about this equity lens by telling the story, the data, the people, and really it gets us to this point of being able to envision a healthy and equitable future requires an honest assessment of where we are now What is that baseline health status? And what is on the horizon? What are the coming risks? And it also requires us to think about our levels of influence, our different levels of influence, from the individual all the way up through institutions and international levers of influence. And I want to use an example about thinking about the intersecting possibilities and opportunities if we think about climate solutions, as well as solutions for other public health problems. In this case, I'm using childhood obesity, which is a massive epidemic in the United States. So I want to highlight 3 examples here at these different levels. So one would be thinking about farm to school programs, getting more local food, more fresh fruits and vegetables into the diets of children. We reduce food production energy when we do that, which is a win for climate, a win for the environment, and it's also a win for children in terms of what nutrition they're getting, what nutrition is getting normalized at school, and what they will grow up to think of as their normal diets. Another example, we know that things like street tree initiatives or greening, in this case, this program called Concrete Safaris, which is a New York City program that does urban gardening and street trees, will help to decrease the urban heat island, which decreases people's heat exposure. But we also know that green space increases physical activity and all of the neuropsychological benefits of green space. The third example, at a different level here, at the school and community level in this example, is programs that are looking to design proactively streets that speak to not just the cars, but also the walkers and the bikers and any other mode of transportation. This type of program has been shown to reduce vehicle miles traveled, also increase perceptions of neighborhood safety, and encourage physical activity. So we return, as I start to close, to this story of Kali with the multiple challenges facing his family. And I want to encourage us to think about what it would mean to support not just Kali's health and development, where he lives, where he learns, where he eats and sleeps, and where he plays, but also to think about those that support him and what would that mean to build resilient communities that foster resilient families and grow resilient children. I'll leave you with this quote from our colleague Ari Bernstein, that there will be no health equity without climate action. Thank you very much.
Thank you, Perfy. Dr. Sheffield, not only a perfect time controlling, but also I think we are very much motivated and touched by the focus of inequity and how we look at the social injustice when we visiting every issues really environment and children, because there is always a story behind, and especially I think with a very holistic presentation by Dr. Sheffield through her work. And we were also reminded that international partnership and an effective network probably can best facilitate our future work. So thank you again. And we will now first move to the second speaker, and with final presentation by Professor Long, Candice Long. And after that, we will have the joint discussion. That's how the session will be run. So I hope you are informed as well. So our second speaker would be Dr. Rebecca Phillips-Moran. Are you there online already? And she is the assistant professor of pediatrics from the Emory University School of Medicine. She has completed her education, both undergrad at Princeton, as well as a Master of Public Administration from the Columbia University, and later to start her medical training and education at Emory University. She has already, up to this point, recognized through quite a few awards, including the Excellence in Partnership International in Launch the Child Health and Mortality Prevention Surveillance Network. I think she's the best and positioned to give us the second talk for this session. So welcome, Rebecca. The time is yours now. All right?
Thank you so much. Can you hear me okay?
Yes, now.
Perfect. Perfect. Thank you. And thank you so much to our host, and thank you, Dr. Sheffield and my colleague, for that wonderful presentation. I'm happy to talk to you all today about child health benefits of climate solutions. And I'll start with the same disclaimer and funding acknowledgement as Dr. Sheffield, recognizing the American Academy of Pediatrics and our pediatric environmental health specialty units, as well as ATSDR, CDC, and EPA. Dr. Sheffield talked about why climate change matters so much for child health and health equity, and that we're already seeing the implications of climate change right now. As the Lancet Countdown stated in 2019, it will take all of us, the work of the 7.5 billion people currently alive, to ensure that the health of a child born today is not defined by a changing climate. But at the same time, climate change has been called the greatest global health opportunity of our time. The healthcare sector, those of us who provide care in medicine and nursing and in public health, are increasingly raising our voices. And just like Dr. Sheffield said, we're telling the story of why this matters for health. In September, this editorial was published across 200 leading health journals, calling for emergency action to limit global temperature increases, restore biodiversity, and protect health. That we're saying that we see these inequities and that we feel this urgency of preparing our workforce now. And even more recently, just last week, I guess a week and a half ago now, this year's Lancet Countdown on Climate and Health emphasized the opportunity of the moment again, that climate change is integral to a healthy recovery from COVID-19 and to health equity, and that accounting for the costs of carbon and the costs of inaction justify what we need to do to decarbonize. But the authors also emphasize that the kind of unprecedented collaboration across sectors around the globe is far from certain. They call this a code red for health. And this is also a code red for children's health. Another recent publication, this one from UNICEF, and you can access it there with the QR code in the corner, really emphasize why the climate crisis is a child's rights crisis. We learned from Dr. Sheffield how a child's risk to climate is multifactorial, a function of greater physiologic vulnerability that all children share because they're still developing, as well as the risk of exposure to climate health harms and the ability of family, caregivers, and community to adapt or buffer their children when they are exposed. And what this UNICEF report really calls out is that greater than 99% of children around the world are exposed to at least one climate or environmental hazard, shock, or stressor. This is so many of our children, and so many are exposed to more than one. So as we think about the cost of inaction, let's think about what this means for our children. So as a planet, as we've heard, we passed the 1 degree warming mark in 2017. The Intergovernmental Panel on Climate Change says we need urgent reductions of emissions, 45% below 2010 levels by 2030, and we need to be a net zero planet by 2050. This is avoiding those consequences of climate change that are unmanageable. But we also know that we're stuck with some of those consequences of climate change, and we need to adapt our cities, our infrastructure, this includes our healthcare infrastructure, to those consequences that are now inevitable. But these aren't just abstract terms, mitigation and adaptation. Mitigation means that we're decreasing a child's risk of exposure to harms from climate change. Adaptation means that we're improving the ability of our communities to buffer children from these harms. The outcomes of this are that we have an opportunity here with climate action to save child lives, to prevent illness, to avoid disruptions to childhood, support child rights, and promote health equity. Dr. Sheffield discussed the profound social and intergenerational issues inherent in the climate crisis, that those who contributed the least are those who are at risk of suffering the most in terms of loss of life and land and livelihood. And from a global child health perspective, The highest rates of mortality already exist in places where the most children live and where the most children are expected to experience harm from climate change. This is what our children feel. This is why we need to elevate their voices. They feel that we will die of old age, but they will die from climate change. If we zoom out, though, reduction in global child mortality is one of the ongoing success stories in global health. In 1990, there were more than 12 million children who still died each year. We've more than halved that number to just around 5 million children now. But the flip side is that there's still around 5 million children who die each year from preventable causes. And in a changing climate, we risk reversing this progress. So let's look a little bit more closely. And some of you may be familiar with this pie chart. This is United Nations data showing causes of child mortality in children under 5. I think it's important to see how climate change intersects with this pie chart. So heat itself can cause increase in preterm birth complications. That yellow section of the pie chart is just death in the first 28 days of life. It's almost half of the death in children under 5. And extreme heat can increase that risk of preterm birth as well as congenital anomalies. It contributes to that. Air pollution contributes to that same preterm complications as well as to childhood pneumonia, which is the leading cause of death in the greater than 28 days to 5 years old. Extreme weather events related to climate also expose children to flooding and risk of injury. They can disrupt water, sanitation, and hygiene infrastructure, leading to diarrheal diseases. And of course, in addition to diarrheal diseases, climate change is altering global patterns of other infections like vector-borne infectious diseases, including malaria, dengue, and Vibrio. What's missing in this chart? Malnutrition, which of course contributes across all of these causes of child mortality and is also mediated by climate change. So this is where, when we look at how climate change interfaces with the global development agenda and global child health, we see an incredible convergence of opportunities here to accelerate progress in both realms. Some of the highest impact investments that we have for mitigation to avoid the worst consequences of climate change have enormous co-benefits for child health as well. These are just some of the examples, and many of these overlap. So educating girls has benefits for both climate adaptation and mitigation. In fact, a girl's education contributes to her community's resilience. And I'd encourage all of you who work in global health to think about where you are, your day-to-day work. What do you do in your day-to-day role where you could bring climate change into that platform and help us reach this unprecedented mobilization across sectors that we need? Let's look for a second just at mitigation. When we account for the health costs of carbon, major near-term benefits provide added justification for those policies to reduce emissions. So looking just at diet and pollution, it turns out that red meat accounts for 30% of greenhouse gas emissions from our food production system, and that more plant-forward or plant-based diets are not only good for us, but are associated with benefits for our planet. A key finding from this year's Lancet Global report was that between 2017 and 2018, the estimated deaths due to excess red meat consumption rose by 1.8% to 842,000 deaths. Those are deaths that are avoidable with a different diet. In fact, the Eat Lancet Commission on Planetary Health convened experts at just this junction to look at the opportunities around diet for the planet. They concluded that food, something we all depend on every day, is the single strongest lever that we have to optimize human health and environmental sustainability. But that's the question: how do we achieve diets for the global population that give us the nutrients we need and support the health of the planet and future generations? They looked, again, they calculated by different measures how this diet would actually save lives. And I love these charts that show how far or close we are to a planetary diet around the globe. We can see at a glance that global transformation to this diet means substantial shifts across the world. So in some areas, and you can see here with the orange circle, the global current intakes in different food categories. So in some areas of the world, this means doubling down on food security and nutrition interventions programs to ensure that areas are able to get adequate nutrition and adequate micronutrients. For other countries, and you'll see the region of North America, like the US, we're responsible for greater carbon emissions already. And this means for us eating less red meat, eating less processed food, eating more vegetables and healthy choices like nuts and fruit. And this also means wasting less food with more efficient systems. So switching to this more planetary diet will reduce an individual's risk of chronic disease, reduce healthcare costs by reducing individual risk of chronic disease and that burden of those preventable chronic diseases, and it's better for the planet. When we talk about pollution, 90% of the world's children are exposed to air pollution that exceeds WHO standards. This is what we need to remember for the climate crisis. Children are the face of the climate crisis. And in the US, the transportation sector accounts for over a quarter of total greenhouse gas emissions. At the same time, as Dr. Sheffield mentioned, we have an obesity epidemic and our population suffers from lack of physical activity. So this means for individuals who can access this more active transportation on bikes, on our feet, taking subways and buses, less times in cars has benefits for both local air quality, actually community cohesiveness too, along with decreasing global emissions and contributing to what we need to do in the climate crisis. So when we center health, the message is clear. Rapid decarbonization could prevent excess deaths from air pollution, excess deaths from red meat consumption, and result in better physical and mental health from higher exposure to nature and more physical activity. And when we flip over to adaptation, remember, children depend on their caregivers and communities, and climate change disrupts and strains these caregivers and community in multiple ways. So let's just touch on how these converge with child health benefits. I want to go back to that UNICEF report and this climate health risk index. They're looking at those same factors, a child's risk of exposure and a community's ability to adapt and buffer children, but this time on a national scale. How well does a country do at centering a child's needs? And the US is kind of right in the middle purple color there, right in the middle on the ranking list as well, as we have not historically done an adequate job of centering the needs of children in public policy, and the COVID pandemic was another example of that. But UNICEF really underscores that we have an opportunity here by focusing on what children need anyway in climate adaptation to protect children in the climate crisis. So investments to improve health and nutrition services could protect 460 million children in the climate crisis. Investments in education could protect 275 million children. And investments in water, sanitation, and hygiene across the globe could reduce overall risk for 415 million children. This is the convergence of opportunity. And I'll mention briefly that we need to remember that climate change is a threat multiplier. So we need to think about how to safeguard health delivery against multiple disaster scenarios. And we're starting to see literature like this emerge from the pandemic, places where there were climate-driven disasters at the time of global pandemic, and in Mozambique's case, terrorism as well. Even when our healthcare infrastructure is not in the direct path of a disaster, we're vulnerable to climate risk. As we saw in the US when Hurricane Maria struck Puerto Rico, and there were global supply shortages of things that we rely on, like IV saline bags and certain types of antibiotics. And there are tools now to help us adapt, and those tools are centering health. What we need to do as the community as well is make sure we center children in that health. So this disaster resilience scorecard for cities, this is a public health addendum that's available in multiple languages from the UN site. And I just want to show what that looks like. This shows one metric, community access to and trust of public health information. To what extent do communities receive it? And it ranks from 0, no attempt to convey public health information, to 5, or the best would be public health advice has been shown to be received, accepted, and acted upon. There are several different metrics that tools like this enable us to rank where we are so we know where we need to go. And we just need to keep remembering that children's needs are different. So I'm going to end with a hopeful thought, and that's where many of us spend our days in the healthcare sector, caring for patients. There's an enormous opportunity. So if we pause and think right now about how many physician doctor visits are going on all over the world, these offer an opportunity to talk to patients about climate-related threats, to screen for those health harms that patients may be seeing from climate change, and help prepare our patients for what we expect they may experience. It offers a chance for us to advocate for stronger connections between healthcare, public health, and community services. And it gives us a chance to think about promoting health, like we talked about with diets and active transportation, not just at the level of one patient who has become sick and is in that hospital setting, where far too often we practice medicine now in a very reactive way when illness has already occurred, but to think about how we can promote wellness from the self, the family, the community, and all the way up to the planetary health level. Those opportunities to support both at the same time. These and other climate solutions support a healthier environment for children of today and a healthier future for children of tomorrow. So now every degree Celsius matters and all eyes are on COP26. Let's make sure they continue centering the needs of children, continuing listening to the healthcare sector who is prescribing urgent climate action. And I'll end, as I end all of my talks, if I may, thank you all for this opportunity and ask if you could reflect on what's one thing you can do in your day-to-day work to think about the climate crisis and how you can center the climate crisis and contribute to a healthier and more sustainable world. Thank you.
Thank you, Dr. Phillips-Warren. I think by joining this session, by meeting here today or through online, we are all doing that one thing we can to contribute to a sustainable world, I believe, from our discipline, our education. I think with the previous two talks from 2 medical doctors, we are now having at least the ample understanding toward how the aspect of social injustice, how the aspect of inequity are emphasized, especially when we tackle from climate change issues and looking at children as our most vulnerable and targeted audience. But I think we are also understanding that the area of environmental science are just as equally important, because this is a field that require adequate understanding from both sides. Medical doctors should have probably also as much literacy and understanding toward the environmental mechanism as much. For the environmental scientists, they need to also move further to appreciate how the medical aspects or the health consequences are structured, and so that we can move together for a shared and joint outcome. So with that, our third speaker and last speaker, before we move to our joint discussion, please join me in welcoming Professor Candice Long. We came from the same school back when we did our study, but I think she has a perfect background as the ending talk for this session. She has undergrad training in atmospheric sciences and later had a complete education in the area of School of Public Health. And after coming back to Taiwan, she spent most of the time dedicating to either inventing better monitoring devices or linking that epidemiologically to struct and build a foundation for fuller understanding towards Taiwan's health condition, especially with children. And she will bring to us two concrete examples, focus on PM 2.5 as well as the heat stress. So Candice, the time is yours.
Thank you. Okay, thanks, President Su, for the kind introduction, and also thanks Health Promotion Administration for the invitation. Previous two speakers has given a large framework about child health and climate change, range from nutrition to air quality to heat stress and also to infectious disease. And in the following presentation, I'm going to introduce two field studies focusing on children's heat stress and PM 2.5 exposure near or in school fields under climate change. And okay, so we all know that under climate change, we will experience more frequent heat waves with extreme temperatures. And we will have, okay, so under high temperature condition, the fugitive emissions of a volatile organic compound may be higher, along with a higher photochemical reaction rate, resulting in higher levels of the secondary pollutants, such as ozone and PM 2.5 in ambient air. So people will be exposed to high levels of pollutants, as well as heat stress on hot days. Okay, so today we are going to focus on children, actually focus on students with age from 7 to 15. It's a school age from elementary schools and also junior high schools. So they may be exposed to heat stress during outdoor activities and in school fields. They may also be exposed to peak exposures of PM 2.5 when they go to schools and they were in close contact with certain PM 2.5 sources around their schools, inside their communities. So I'm going to introduce later. So today I'm going to introduce two field work, okay, using local sensors to assess. One is for heat stress, another one is for PM 2.5 exposures. And with these local sensors, we actually can collect data with much finer spatial temporal resolution than the typical data you can get from the Central Weather Bureau, CWB, or Taiwan EPA. Okay, so this is a simple framework of our research, a diagram of our research framework. We are focusing on one of the vulnerable population, children, and they will actually assess exposure from both direct and indirect pathways. Okay, that is heat stress and PM 2.5. We also try to focus on evaluating different intervention strategies in order to interrupt this exposure pathway so we can reduce children's exposure and also their associated health risks. And so we all know that exposing to high heat and PM 2.5 will lead to certain health impacts. And for children, they are particularly vulnerable because they are immature physically and mentally, and also they may spend more time outdoors due to physical education or outdoor leisure activities compared to adults. And most importantly, any impairment in cardiopulmonary functions in early age may lead to reduced life quality for the whole lifetime. So it is important to reduce children's exposure to heat stress and PM 2.5. Here, the right-hand side is an article of New York Times 6 years ago, emphasizing that heat is not only, related to temperature, but also related to relative humidity. So today I'm going to use a heat stress indicator used in public health field for the past 60 years. Okay, that is wearable globe temperature, WBGT. This indicator consider not only temperature and relative humidity, but also solar radiation and wind speed. We all know that we experience hotter under direct solar radiation, and we feel cooler under high wind speed. So it is important to consider all these weather parameters for heat stress. And for assessing students' heat stress exposure, actually our group set up 15 local sensors around Taiwan in elementary school or junior high school. And we also conduct 6 intensive observation campaigns. We also use data from one of the Central Weather Bureau CWB station in New Taipei City for comparison. After excluding raining hours, we use temperature, relative humidity, solar radiation, and wind speed, and to calculate wearable temperature and globe temperature based on formula developed by U.S. National Laboratory in 2008. And then afterwards, then we can calculate WBGT based on the combination of wearable temperature, globe temperature, and air temperature. And for today's presentation, I will present data mostly focused on 8 a.m. to 5 p.m. during May to October, from May 2016 to July this year. Okay, so so we use this type of movable weather station with all these local sensors. And this local sensor, the data quality meets the requirement of the World Meteorological Organizations. With solar panel, actually we can obtain data in any places with sunshine. And also with wireless transmission, we can obtain data in real time. Currently, Taiwan's Central Weather Bureau cannot provide solar radiation in real time. Therefore, our sensor network is the only sensor network who can provide WBGT in real time. Okay, so we set up all these weather stations in different schools on different services. So typically for standard weather station, they are required to be set up on the grassland. Okay, this is a requirement by World Meteorological Organization. And however, we encounter different surfaces in daily lives. And so this concrete surface actually have higher heat content. So we experience higher temperature on top of these surfaces. So we purposely set up this weather station on different surfaces in order to assess actual heat stress students are actually exposed to. Okay, so here is our data. So here is, from May 2016 to July this year, and we show the monthly mean of 21 sites and CWB, so you can see the variation, okay, among them. And you can also see the temporal variation for temperature and WBGT. And the temperature and WBGT are both getting higher in recent years. Okay, and I also want to point out the highest is all occurred in July last year. Okay, and I want to emphasize that some of the monthly mean of WBGT actually is already in the range of the dangerous zone. Okay, this is criteria for 4 categories of the heat health warning in Taiwan. Okay, so the criteria actually is the daily maximum hourly WBGT above 32, 34, 36, and 38. Okay, this criteria was established based on our previous research work. And we analyzed in 20 years of the weather and health data in Taiwan. And then we identified that significant increase in heat-related emergency visit above 32. And the relative risk is even higher above 34. So this actually is used by Central Weather Bureau and Health Promotion Administration as a heat health warning category in Taiwan. Okay, so we can see that some students in certain schools already experience, okay, the WBGT in dangerous zone. Okay, here is, I show data in 8 sites, okay, and then this is the distribution of the monthly, hourly, the maximum hourly WBGT distribution in each category, okay, for each month. The white color means that it's below 32, okay. We can see that one station in northern Taiwan, in Taipei, actually have high percentage in danger of WBGT in dangerous and highly dangerous zone. Okay, another station is in southern, actually it's in Jiayi. Okay, it's also experienced a high percentage in dangerous and highly dangerous categories. Okay, so I will show some summary table for these stations in northern, central, southern Taiwan, and eastern Taiwan, and also CW stations here. And so here is the percentage of the days of these 6 months in each year above 36, okay? The cell with the higher coverage in red shows the higher percentage. So you can see in Jiayi, actually, more than 40 to 50% of the time actually is above the dangerous category, okay? And the one in Taipei actually is above 30 to 40% of the time. It's actually in the dangerous or highly dangerous zone, okay? Of course, there are also schools, okay, with very low percentage of the above dangerous criteria. And the CWB actually has lower percentage, okay, percentage of days above 36 because it took measurements on grassland. So actually that make the data observation lower. Okay, so we can see this huge variation temporarily and spatially with the number 1 here, number 2 here, and even in the eastern Taiwan, we have number 4. Okay, so we can rank these the WBGT based on this. Okay, so we also have another finding. We find that higher WBGT actually occur before noontime than WBGT in the afternoon. Okay, this is very important because usually school may schedule their outdoor activity in the morning because they think in the afternoon the temperature is higher. But actually, the heat stress, the WBGT is actually higher. Okay, this is an example in northern Taiwan, but actually it's occur all over Taiwan. Okay, WBGT is higher in the morning compared to in the afternoon because the solar radiation is 50% higher in the morning. The reason is that because Taiwan located in subtropical, so we have thunderstorms in the afternoon. So beginning at the noontime, the sky is covered with clouds, okay? So they block the solar radiation. It caused that actually the WBGT is actually higher in the morning compared to in the afternoon. So this has a significant implication to schools, okay? Because schoolmaster has better to reschedule their class of outdoor physical education in the morning rather than in the afternoon. Okay, so this is a very important message. And also we compare WBGT reduction among 3 different intervention strategies. The first one is, okay, students stay indoors with air conditioning on. So with reduced temperature, relative humidity, solar radiation, and wind speed, so the WBGT can be reduced by 6 to 7, okay? And another option is without electricity, only open window, okay? So the solar radiation is low and temperature is low, and the WBGT can be reduced by 3 to 5. And the third option is, stay outdoor under the shade. Okay, so the other 3 parameters stay the same, only blocking solar radiation and then the WBGT can be reduced by 2 to 3. Okay, so these are useful strategies that school can use to reduce students' heat stress. Okay, the second study focused on students' PM 2.5 exposures. The previous one, we set up stations all over Taiwan, and for this study, we actually focus on central Taiwan. And for one school located in an area ranked the 4th of the worst air quality in Taiwan in 2017, with more than 150 days above AQI. Okay, so we actually using our research instrument on a moving car and circling around these schools. We took measurement and identified several hotspots with emission sources. So we set up street level sites, okay, around this community near certain emission sources like traffic intersection near traffic or near these fried chicken vendors, okay. And we also set up a high level site 10 meters above ground for ambient comparison. And then here is the local sensor we used. AS-LAN-O is integrated by our research group in Academia Sinica. Okay, we actually calibrated against research grade instrument one by one, and so we can translate their signals to research grade observations. We set up them along the street in the light pole, so we can actually measure the exposure in the street levels. Okay, so the mean level actually is indicated here is higher in December, lower in July. However, if we're looking into the peak exposure is much higher than the mean level experienced. Okay, so here is the two cases, one in July, one in December. For these 11 sites, you can see the temporal variation and also the spatial variation among these different sites. And one station, one site with the high exposure, even in the, especially in December, okay, they have months-long high exposure because it's near a temple. They have a cultural activity months-long. So people will experience to high PM 2.5 near that site. And while it's actually sometimes near even about 500 microgram per cubic meter. Okay, so the peak exposure is what we concerned about when we near certain emission source. And certain fenders or traffic zones also experience, will also have high peak concentrations. Okay, so we can compare the PM 2.5 in street level and compare to the high level side. You can see the ratio. We all know that, of course, in the street, because we are very close to certain emission source, the exposure will be higher. But how much higher? Okay, on average, it may be 10 to 30% higher compared to the high level side. Okay, because we use local sensor, we can collect enough sample size to do regression analysis. So in the end, we can quantify the incremental contribution of PM 2.5 to different sources. So we suggest that Taiwan EPA should, prioritize and to control for these community sources and to reduce students' exposure. I know that because Taiwan is densely populated, so we have a lot of different community sources inside our community, but the U.S. may have different community sources. But we think this is a very important message. Okay, so based on the previous field study, we have this recommendation. For regular preparedness, we can provide strategy to avoid heat stress and PM 2.5 to students. We can also link to heat and air pollution alerts with weather and health APP. Okay, this is a collaboration of the HPA and CWB. You can search online. Okay, it gives you a file resolution in township app to tell you the heat levels, WBGT levels. the school can also set up local sensors to monitor heat stress and PM 2.5, so they can, take immediate actions if they found out there's high exposure to heat and PM 2.5. They can also pay attention to susceptible population with pre-existing disease. And so we also provide several strategies to reduce WBGT exposure, and also under air pollution alert, we can avoid community sources and also move class indoors. Okay, so in conclusion, I present the field study to indicating high exposure of our students to heat stress and also PM 2.5. And also I demonstrate the advantage of using these local sensors. This can be used to monitor children's heat stress and PM 2.5 exposure for a long time because it's much cheaper. So we can monitor their exposure under climate change. And in the end, I want to acknowledge the funding support from Academia Sinica MOS and Taipei DEP, and also the support from local community and schools, and also the recommendation in these stakeholder meetings with HPA and CWB, and also other governmental agencies. And I would like to thank the team member of our 2020 Presidential Hackathon, Weather and Health for All, for establishing this app. Okay, in the end, thank you very much for your attention. Thank you.
Okay, thank you. Thank you, Candace, for given I got a sort of beautiful, detailed case studies to address two important environmental stressors, both include PM 2.5 and heat stress. I think in particular, studies and research on these sort of health consequences of children on these two particular stressors are most publicized and appreciated. But over the years, I think at the end of the session, we can all come back and to invite three speakers to comment on as to how all these peer-reviewed and already published findings can be directly linked to policy changes. It would always take some efforts, both at the academic level as well as the recognition and understanding from the bureaucratic process to make it happen. And eventually, we even require further information to link or to amend that particular gap before the ultimate benefit for the children to enjoy. So we'll come back to visit that. And I was told there were already two sort of questions or inquiries from the audience, right? Is it already there? Okay. Is it shown someplace? Okay. No, this is fine. I just want to maybe relay those questions to our speakers online. Maybe it's on your phone? Oh, okay. I see. So Perry and Rebecca, the questions will be posted up on the screen. I do not have it yet, but they have retrieved it from the audience or participants online. And I know one of them specifically addressed to Rebecca, but the first one I think was posted to all three of you. Where's it now? Maybe I can just, it's not there. Oh, okay. Oh, okay. If you don't mind, maybe I can invite questions from the participants and audience on this venue site first. Are there any immediate ones? Okay. If not, maybe I can relay one first. Okay. Is it ready? 你要我念吗? Okay. I'll put it this way. It's easier to this way. Okay. For all three of you, children are at the forefront of advocacy in climate change. And how can we, in our positions as health professionals and government governance. Okay, I believe this governance. Okay, create opportunities for them to have a voice at the table about their future. Nice. Did you get that, Perry and Rebecca? Okay. I think I will invite Perry to start since you had some time to rest after the first talk. So would you mind responding to the first inquiry? Thank you.
Sure. I strongly agree that children are at the forefront of the advocacy, and it does not take a lot of effort to find the children locally who are leading these groups. And certainly there are examples internationally now with some amazing efforts and some attendance at some of the international conferences. But I would encourage people to think local when they think about youth and raise up those voices and invite them to the table, as the question implies. And I think that it's only a matter of acknowledging that they are already at the forefront, and then figuring out ways to engage them even more in the opportunities that we as older humans have. So I appreciate that question, and I am on a learning curve myself, and have been incredibly surprised and rewarded. And we've been able to include youth in as things as local as a fall festival here in New York City at a local public school, where there was local environmental groups, to national conferences that we've helped organize with the American Academy of Pediatrics, or otherwise. Thank you.
I believe we will have our own shared feedback and comments with the experiences working here in children health study, but we'll come back later. I think the floor should be given to those who raised the question first. So Rebecca, would you like to comment as well or respond to the inquiry?
Sure, I'd be happy to, and just echo what Perry said. This is a place where we work with children every day in our clinics, and I think one thing that we've seen in the pediatric world is switching from advocating for children to advocating with children. The other thing that we've really, both of us have been working on too, is educating youth, and that includes our medical students, who are those individuals who are really leading the integration of climate and health content in medical curricula in the United States. And it's kind of this notion of, there's a lot of talk that health professionals are trusted voices in the climate crisis, but I think there's also a component there that perhaps instead we need to also be trusted listeners, and that means listening to our children and elevating other people's voices. But thank you for that question. I think that's exactly what we need to keep challenging ourselves.
Great. I'm going to give Candace her share to feedback first before we maybe could have a dialogue among three of you or four of us, because for this particular sentiment as to how we can even more collectively getting those voices out. I think with pediatricians like you two, it's a daily exercise, it's a daily work, a daily opportunity to be directly linked with the children and listen to them, and then getting their voices through your work. And for those of us who are the environmental scientists, that we often would have to go out and go through some sort of channel and some procedures before we can directly have the access toward the children themselves. So it's a sort of a logistic or bureaucratic process, and often that becomes another hurdle really to break through, to make sure that we could have the full access to their individual's input. But Candice, this should be really your time to feedback.
Okay, as professionals, I think we can collect more data really to serve as a scientific evidence what kind of impact, health impact children has been encountered to or being affected by climate change. And after we collect more this scientific evidence, we can be sure, like a platform like this. I think this is a wonderful platform for all these scientific evidence to be presented, and then collectively, they maybe make, more voice and more as a group, so we can have more force to really promote children's health. So I think that's my point right now.
I think we will leave it at that for the first feedback before we entertain it further as to how our individual experiences are. And there's another one, goes directly to Rebecca. Is the disaster resilience scorecard using any metrics on planetary health literacy? That's something. Did you get the question?
I did get the question
Okay.
on if that UNDRR scorecard has a metric on planetary health literacy. I don't think it is mentioning planetary health. That's a great idea. I think what we do need is training of healthcare professionals, like this question is implying, beyond just climate change. We need that. We really need that, but also taking that one step further to that broader lens of planetary health. I think that's a really great point.
Okay, great. That's actually for the two questions that from the online audience that have been given to me. We have a few more actually minutes to go before we end the session. I was wondering, Dr. Lu, do you have any comments or input, since you were very, very much a key instrumentally important to organize and to make this event happen? Any? Wow.
Hi, thank you, Dr. President Su, for asking me to come up. But I'm actually quite honored to be one of the few who started the collaboration when I was posted in US, DC at the time. As a pediatrician, actually I have a very keen interest in this topic. One idea is that when environmental impact do work on the children's physiology and the pathology, we do find almost all the time the effect of this impact be found much later, even when they were already being in adulthood. That leaves the pediatrician very difficult to challenge and intervene clinically. So may I ask if our colleagues in states already started with the investigation in this kind of impact from the precision medicine point of view, because genomic effects from the disease, as well as some of the environmental impact, has been documented in other research through the genetic and effect, the genomic effects. Yes. Would that be possible to show us a bit of this leadway? Maybe we can include this in the future, because I need this information for the time being. Thank you.
Okay, I was just wondering, Perry and Rebecca, do you both get the questions well? You took the questions well? Were you able to get the questions or the inquiries from Dr. Lu? Were you able to? Rebecca, you can. Yeah. Perry seems to be puzzled.
I think.
Okay.
I think that the question was around how so often the harms to children from environmental exposures manifest clinically much later. And are we doing anything in our research or work to consider how these exposures are affecting children? And I guess now thinking almost like in terms of genetic expression, even I was taking the question almost to mean like an exosomic lens. Does that sound right?
Yes.
Yeah, I think that's a great point. And I think that we're at a point in the climate crisis where we have lots of evidence-based emerging showing the health harms to children from climate-related exposures. And we are at a point where we need continued evidence supporting how we translate that into clinical care. And there are some exposures, so I think that's a fascinating area of study. I am not doing research on that area right now, but in the clinical setting, there are some ways that we can bring climate into our clinical practice now. And some of that is around preventing these exposures. And extreme heat is a good example for something where we actually do see some of the risk immediately with heat-related illness and heat stroke, and unfortunately even death in children athletes in the United States. And so one way that this comes into practice in the pediatric office for me now is giving guidance when in the US, when children need to participate in sports, they come to their doctor for a sports physical paperwork, and we talked about prevention of heat illness. When a child has asthma, we talk about thinking about the air quality index or the level of pollution on that day and how that may matter for their asthma management, trying to empower them. And I think there's even room to look at what we know about climate so far and what that means for rapid recognition of climate-related illness in the hospital setting, how this would change our hospital policies and protocols too. When children are ill, it may be from climate-related infections or from just recognizing heat illness, kind of like we're pretty good at recognizing severe bacterial infection and sepsis now. So I know that's kind of how I bring this into clinical care now, a little different from the really excellent question you alluded to, how much work we could do in that more exposomic study. I'll let Perry help me out here with her insights as well.
I thought that was great. I totally agree. And I think that the question points to the cutting edge of exposomics and epigenetics. And similarly with how environmental health for all the other exposures has evolved. We first look at we count the deaths typically first, and then we start to look at the overt clinical manifestations, but then we start to realize that environment affects us in insidious ways. And so, like Dr. Phillips-Bourne was just mentioning, I imagine that on the horizon, we will be able to understand more exquisitely the subclinical effects of things like heat exposure, certainly pollution, we're getting there already, and that it will just further underscore sort of the importance of having clean air, water, environments to raise healthy children and healthy populations.
Candice also have some input, please.
Yes, actually, I agree with the previous two speakers. In addition to clinical practice, actually, I think for environmental health, it's more important to do prevention, that is to stop, to interrupt the exposure pathway, and to reduce exposure is the most effective way to protect children's health. For example, we are wearing masks right now. This is a preventive, to reduce the exposure of COVID-19. And of course, we take vaccine, but vaccine is, afterwards. After something already happened, well, it's preventive is okay, but actually, if we can, all wear mask and also taking vaccine, then we will protect ourselves more. And for children, for example, we already we all know from literature that children will be exposed to high PM10 or high PM2.5 or high heat stress or bioaerosols. Okay, we all know that. So there is no point to following up to obtain more evidence of what kind of children already got impact to. And the most important thing is to really interrupt the exposure pathway to reduce exposure to bioaerosols, fungi, PM2.5, and all those things. and then so we can protect children's health. I think that's more proactive way. Thank you.
Just a side point, you know, we're a very law-abiding society, so we've been vigorously wearing masks for probably more than 18 months now in a way. And I just recently have feedback from my students and assistants. It poses another great challenge to really investigate environmental exposure and the true outcome. Because oftentimes, their hours at school or the other places or potential exposure site are all well cleaned, well protected, and we wonder that's how typical is that would be posing as part of the exposure profile when the pandemic is in other form of control. But this is all new. We are in a totally new era as well. As far as linking the sort of hereditary or genomic information and the others, I think Perry, Dr. Sheffield also mentioned the part of the effort in further data collecting through all sector and platform. That certainly is also part of the data. So how we could at regional level, national level, or the other sort of co-effort to, under some sort of guidance and supervision, to share those information in a more open and effective way, certainly I think would also benefit the children's health in a more speedier fashion. I think that's a huge challenge in anything that we do. You know, often it's hard to go beyond one hospital, let alone cross-institutional collaboration. So we'll see how it goes. Okay, do we have time for another one? Okay, let's take this opportunity, and since we have you there, clinicians often treat patients presenting with a clinical problem. How can we motivate clinicians to actually look deeper into public health to create a mitigation and adaptation strategy that I couldn't recognize, huh? A benefit, okay. I couldn't quite read it writing yet. That benefit our population. So I think this goes to the to medical doctors. So start with Dr. Sheffield, maybe? Yes.
Sure. I think just like right now at the Conference of the Parties at COP26, they're talking about creative solutions to climate financing. Part of the answer to that question about how do we motivate clinicians is that we shift some of the financial motivations and incentives, and some of that has to be driven by the insurance companies or a national health program toward prevention and sort of reimbursing for that. We're working on different ways to bring environmental health into clinical care and working on the financing part of it, and some of that will be from the ground up, and some of that will have to be from the top down in terms of particularly the way that healthcare is financed in the United States right now, for example. But I think that's one of the challenges and also opportunities of climate change is that it requires us to think outside the box and bring in different collaborators across disciplines to answer those kinds of questions.
Okay.
Rebecca, do you have more?
Dr. Phillips-Ward? Rebecca, would you like to? Yes.
Yes, thank you. I completely agree with Dr. Sheffield's answer and think that this question really is about prevention and where we practice medicine and that responsive reactive realm, or in that realm of preventing illness before it starts, preventing exposures if we can. I do think the urgency of the climate crisis is starting to be more of a motivator for some clinicians too. We are seeing harms that are happening when we don't engage in that preventive realm. And clinicians don't want to be in a situation where we're treating illness that's happening that's avoidable. So I think that can be a motivation in itself. And our students come into medicine because they care about humanity and outcomes, and When I talk to the med students that first week of med school, we talk about, yes, you need to learn the details of medicine. We definitely need doctors who can provide the best clinical care when you're in an intensive care unit or when you're in the hospital setting. But don't forget the big picture, and don't forget what drove you to medicine in the first place. And for so many, that is that public health, that preventive realm, this bigger picture.
Great. I realize we're a bit just over time, but we really cannot end the session without the two questions posed by the senior member. Actually, it's the role model of all pediatricians in Taiwan. Professor Lu, Professor Li 教授 have two questions for the session. 老师可以。
I see. I have two questions regarding the risks of the global warming. The first one is to Dr. Sheffield. You mentioned the risks is highest among the Black women. What is the reason? The second question is to the Dr. Long, the last speaker. You said the children are the higher risk among adults. What are the reasons?
Okay, good. 那药师先请坐。Okay. Dr. Sheffield, did you get the first question?
Yes, I think I heard that the question is, why are the climate risks highest to Black women? And specifically, the study that I was showing was an article talking about pregnancy complications. And I think we are coming to understand, partly because we are realizing that some of the ways that we have studied health disparities in the past has not really gotten at the root cause question. But we are coming to understand better how specifically unequal structural policies, some of which specifically discriminated against Black populations in the United States or other ethnic or racial minorities, have had long legacies in terms of differing access to resources, increased stress over entire lifetimes, and myriad other problems. And those are problems of social constructs for which we now have to figure out solutions. And they have deep roots. As I emphasized in the talk, it's not a biologic difference, but it is one that has long legacy now in terms of historical causation and historical ramifications.
Okay, thanks. Candace Long.
Thanks, Professor Liu, for your questions. And actually, for PM 2.5, actually children are at equal risk of adults because they are also children or adults, they both exposed to all these community sources within our community. Because Taiwan has a high population density, so we have, restaurants, temples, small factories, machine shops in our communities. So every time we pass by, then we are exposed to those PM 2.5. So they are at equal risk. But because children, because their lung function is still developing, so they, after exposure, they may develop, higher risk of, develop some impairment in their cardiopulmonary function. So that's physiologically, I think they are more vulnerable. But in terms of exposure, I think they're equal exposure. And in terms of the heat stress, because if we compare to typical housewife or elderly or office workers, stay indoor working, and then children actually spend more time outdoors playing. Okay, so that's why they are exposed to a longer period of time of heat exposure. However, if we compare to workers in construction industry, they may, stay 8 hours or 10 hours outside working, and then, the workers' exposure may be higher than children. So in terms of exposure, there are differences among children and adults and among different occupations. Okay, thank you.
Well, thank you all. I'm actually reminded by the organizer, they have scheduled a session very, very tight. So the following one need to come up very, very soon. On behalf of the session, let me thank both the speakers and the audience, either online or on this venue. You have made the session very, very informative and vibrant. I was told that there have been more than 20 years, actually, the collaboration between US EPA and the Taiwan EPA. But it's only, I think, since last year or the year before, the Ministry of Health and Welfare had the opportunity to propose a specific focus on the topic of children's health and environment. And I think it's been exemplified by the success of this particular format. Likely, the platform will continue to grow and extend it. And hopefully, we'll come back next year with more exciting and meaningful results through the researchers, through the civic servants, and with the core and shared benefit to contribute to the betterment of children's health of tomorrow. So thank you all, and we'll see each other very soon. Stay healthy. Thank you. Thank you.
Thank you.
Okay, thank you to our moderator and speakers of this season, as well as your participation in this morning. We will now take a coffee break and we'll be back for more parallel seasons. To join Parallel Season 5, please move to 8th floor, room 801. To join Parallel Season 7, please remain at your seat. To join Parallel Season 9, please move to 11th floor, room 1101. Thank you.
我有笔，不然呢？不知道哪里卡。
当然完成。先这样就好了。对，2份，然后前面我帮你写，你待会帮我签。
没有问题，就打算帮我
啊，可以的。
哦 ，OK， 好。
来，给你2份。
哦，不好意思。
2份，然后这1份是要给你的。
好，
谢谢，这是大会的礼物。
好。 谢，好。好，那现在不用留给你。没关系。好，我就先留着。好 ，OK， 好，谢谢。
那老师要到我们要。
好，我来说吧。
稍等一下，
你拿着你的。再把它收好。
台湾耶。
然后再我帮你，谢谢，辛苦了，辛苦了。好。
Ladies and gentlemen, Ladies and gentlemen, welcome to Parallel Session 7 of the 2021 Global Health and Welfare Forum. 好，好，好。Ladies and gentlemen, welcome to Parallel Session 7 of the 2021 Global Health and Welfare Forum in Taiwan. Our session will start in 3 minutes. Please be seated, turn your cell phone off or put in vibration mode and keep your mask on at all times. 这样会不会太小声？更高一点点。好。Ladies and Ladies and gentlemen, welcome to Parallel 7, Session 7 of the 2021 Global Health and Welfare Forum in Taiwan. Our session will start in 3 minutes. Please be seated, turn your cell phone off, or put in vibration mode, and keep your mics on at all times. In this parallel session on poverty issues and government's responses under the epidemic, hosted by the Department of Social Assistance and Social Work, MOHW, we have the honor to invite Professor Li Zheng of the National Taiwan University's Department of Social Work as our moderator for today. So please welcome Professor Zheng.
Ladies and gentlemen, it's been a very privilege to moderate this session on the poverty issues. Today in this session, we have 4 presenters, all talking about the poverty governance responses under the epidemic. I will start to introduce the first one presenter, who is a very important mentor in my scholarly field development. It's Professor Mark Rank, who is currently the professor in the Washington University at St. Louis. He is the, hi, Mark. How are you?
Can you hear me?
Good to see you.
Good.
Professor Rank is a very famous expert on the poverty issue in America, who has already published quite a few scholarly articles on poverty, inequality, and the social policy, related to social policy. He is a very influential scholar in America to speak out on the issue of the poverty, economic inequality, who has already advocated several anti-poverty measures. Hopefully the government will take it and reduce the problem among these people. So it's good to have you here in this conference. And I'm looking forward to your presentation. So how about you start it? Okay. I turn over the time to you.
Okay, well, thank you, Li Chen. It's great to see you. And I'd like to welcome everyone as well. What I want to do is talk about the potential impact that the COVID-19 pandemic has had on both the perception of poverty in America and the policy solutions to poverty. So poverty in the United States has traditionally been understood as a result of individual failing. This has taken many different forms. The poor are not working hard enough, have made bad decisions in their lives, don't have enough education or skills, and so on. And in order to avoid poverty, the poor need to work harder and make better choices in their lives. And this idea really comes out of American strong belief in the importance of rugged individualism, that individual success and failure is the result of individual initiative. The underlying theme here is that the causes of poverty can be understood through the lens of individual failure and pathology. As a result, social policies and programs should be limited in their scope. And those that do exist should be focused on providing the right incentives in order for the poor to work themselves out of poverty and to make better decisions in their lives. Now, in contrast to that perspective, what I've argued in my work is that poverty in the United States is largely the result of structural or systemic failures. And I think the current COVID-19 pandemic is a perfect example of poverty originating from a structural failing. So during the past year and a half, poverty has increased substantially in the United States as a result of the pandemic. It's caused businesses to shut down, leading workers to lose their jobs, which then leads to poverty. The pandemic has unfortunately illustrated that poverty can strike many people and that the immediate cause is often beyond their control. So much like the Great Depression in the United States during the 1930s, the recent COVID-19 pandemic has exposed the vulnerability that Americans face with respect to the risk of poverty. So let me take just a few minutes to talk about the perspective that poverty is the result of structural failings rather than individual failings. And again, what I would say is that the pandemic has really caused a lot of people to begin to view poverty as a structural failing. And then what I'd like to do is just take a couple of minutes and talk about some policies that are being discussed in the United States to deal with poverty that, that again, are dealing with the structural failings of poverty. All right, so one of the main points that I've made in my research is that American poverty is largely the result of failure at the structural rather than the individual level. That there simply aren't enough viable opportunities for all Americans. And this is in contrast to the way that we've typically thought about poverty in the United States. That is, that it's the result of individual failings, such as not working hard enough, not getting enough skills or education, and so on. And the argument that I make is that individual deficiencies, such as the lack of education or skills, helps to explain who's more likely to be left out in the competition to locate and secure such opportunities, but it can't explain why there's a shortage of opportunities in the first place. And in order to answer that question, we must turn to the inability of the economic and the political structures to provide the supports and opportunities necessary to lift all Americans out of poverty. And the most obvious example of what I'm talking about in terms of this mismatch is the mismatch between the number of decent paying jobs versus the pool of labor in search of such jobs. So over the past 50 years, the US economy has been producing more and more low-paying jobs without benefits. It's estimated that in the US today, 40% of all jobs are considered low-paying or less than $16 an hour. Since 1973, real wages for full-time male workers have essentially been flat. There haven't been any gains over this period of time. And of course, beyond these low-paying jobs, there are millions of Americans that are unemployed at any point in time, and millions that are working part-time but want to be working full-time. So there's a mismatch between those in need of decent-paying jobs and the availability of such jobs. Now, exacerbating this situation is the fact that the American social safety net is extremely weak, resulting in sizable numbers of families falling through its rather large holes. The US has failed to offer the types of universal coverage for childcare, medical coverage, or affordable housing that most other high economy countries routinely provide. And the result of all this is an increasing number of families at risk of economic vulnerability and poverty. And what I would point out is that the performance of the economy has traditionally been very important in terms of predicting overall rates of poverty. Why? Because when the economy is expanding, more opportunities are available for the competing pool of labor and their families. The reverse occurs when the economy slows down and contracts. Consequently, during the 1930s, or after the Great Recession of 2008, or during the recent pandemic when the economy was doing badly, poverty rates went up, while during periods of economic prosperity, such as the 1960s or the middle to later 1990s, the overall rates of poverty declined. Likewise, changes in various social supports and the social safety net will make a difference in terms of how families are able to avoid poverty or near poverty. When such supports were increased through the War on Poverty initiatives in the 1960s, poverty rates declined. Likewise, when Social Security benefits were expanded during the 1960s and 1970s, the elderly poverty rate in the United States declined sharply. On the other hand, when social supports have been weakened or eroded, as in the case of children's programs over the last 30 or 40 years, their rates of poverty have gone up. The recognition of poverty as a structural failing also makes it quite clear why the United States has such high rates of poverty compared to other industrialized countries. These rates have nothing to do with Americans being less motivated or less skilled than those in other countries, but with the fact that our economy has been producing millions of low-wage jobs in the face of global competition, and that our social policies have done relatively little to support families compared to, say, European countries. And this has been shown repeatedly in analyses that have used the Luxembourg income study. So from this perspective, one of the keys to addressing poverty is to increase the labor market opportunities and the social supports available to American households. Again, poverty exists primarily as a result of a shortage of viable economic opportunities and supports for the entire population. And given this shortage, a certain percentage of the population is insured of experiencing poverty. So individuals with a heightened risk of being on the short end of this economic stick will be those who are least able to effectively compete for the limited number of economic opportunities. This would include those who have fewer marketable skills, less education, ill health, single parents, and so on. So what I'm arguing here is that this approach recognizes the fundamental distinction between understanding who loses out at the economic game versus understanding how and why the economic game produces losers in the first place. There's another way of looking at the systemic nature of poverty in the United States, and that is to look at it across the life course. And much of my research is focused on this question. And this really began with a very simple question, which is, what is the likelihood that Americans at some point in their lives will experience poverty? When I started looking into this, we knew very little about that question. We knew how many people were poor in any given year and how long people were in poverty, but we really had no information about their life course risk of poverty. And so what I've done, along with my colleague at Cornell, Tom Herschel, is we've used the panel study of income dynamics data to look at this longitudinal question. And it turns out that the number of Americans who are touched by poverty is very high. We've looked at this a number of different ways, and the results are all pretty much the same. So for example, between the ages of 20 and 75, it turns out that nearly 60% of Americans will experience at least 1 year below the official poverty line, and 3/4 of Americans will experience either poverty or near poverty. We've also looked at the likelihood of poverty using a relative measure. That is, what percentage of Americans will at some point find themselves in the bottom 20% of the income distribution, as well as the bottom 10% of the income distribution. So between the ages of 25 and 60, 62% of Americans will experience at least 1 year in the bottom 20% of the income distribution, and 42% will experience at least 1 year in the bottom 10%. If we focus on the use of a welfare or a safety net program, we also find very high percentages. So for example, in one analysis, we looked at the percentage of children who would find themselves in a household that used what's known as the SNAP program or the food stamp program at some point during their childhood. And that percentage was 50% of all American children. And finally, if we look at poverty from the broader perspective of significant economic insecurity, we find even higher rates of incidence than these numbers. So in an earlier book that I wrote called Chasing the American Dream, we constructed a measure of economic insecurity that included either using a safety net program, falling below 150% of the poverty line, or having the head of household unemployed at some point during the year. And when we use this measure, we found that 4 out of 5 Americans will experience at least 1 year of significant economic insecurity between the ages of 25 and 60, and half of the population will experience 3 or more years of economic insecurity. Finally, in one other analysis, we found that this life course risk of poverty has really been rising from the 1970s onward. In other words, the chances of experiencing poverty at some point in your life has been rising, even though the annual rates of poverty have remained roughly the same. And the question that I'm often asked is, why are these percentages so high? And the reason why they're so high is that during the course of a lifetime, any number of things can happen to people, many of which are unexpected and detrimental. Things like losing a job, a family splitting up, getting sick, or experiencing a pandemic. And when these events happen, there's often very little to protect families from falling into poverty. More and more families, including middle-class families, are experiencing greater volatility and downward swings in their income as a result of greater instability in the labor market and the lack of benefits such as health and unemployment insurance. So jobs are no longer as stable as they once were, retirement benefits are harder to get, good medical coverage may be difficult to obtain, the safety net has been weakened over time, and so on. So rather than a risk that affects a few on the fringes of society, it turns out that poverty and the use of welfare are events that actually will strike the vast majority of American citizens. And again, this is illustrative of the systemic or the structural nature of poverty in the United States. And this situation has only been exacerbated by the pandemic. So let me now turn to some of the new thinking about solutions to poverty caused by the COVID-19 pandemic. I think what the pandemic has done is it's caused lawmakers to consider policies for addressing poverty that a few years ago would have been considered unrealistic. And in particular, the Biden administration's emphasis has been upon addressing the structural causes of poverty and inequality rather than simply looking at the individual shortcomings. So a good example of this is the newly implemented child tax credit, which provides families with children a monthly cash benefit of up to $300 a month over the next year. Most families with children now qualify for this benefit, and it's estimated that child poverty can be cut by up to 45% as a result. Now, the idea of a child allowance has long been in place in many European countries, but it's really completely new for the United States. And it recognizes the importance of economic support in the raising of children. And such assistance can be a lifesaver in terms of protecting children from the ravages of poverty. Although it's currently scheduled to end after a year, the hope is that the child tax credit will continue into the future and become permanent. So President Biden has proposed a 4-year extension, and Democrats are looking to make it a permanent policy program. And I think in doing so, it would really represent a significant policy change in the United States. So New Jersey Senator Cory Booker recently said, "It's the most transformative policy coming out of Washington since the days of FDR," which was Franklin Delano Roosevelt in the 1930s and 1940s. Another Biden initiative is the effort to raise the minimum wage up to $15 an hour. So far too many Americans, as I was talking about earlier, are working at jobs that simply don't get them out of poverty. In a recent analysis that I did using Census Bureau data, my colleague Steve Fazzari and I found that for Americans between the ages of 25 and 59 that were in the labor force, 31% of them were working at a job that paid less than $16.50 an hour. So by increasing the minimum wage up to a more livable wage and then indexing it to keep in step with future rises in inflation, millions of workers will be lifted out of poverty as a result. And the other thing is that this kind of a policy reinforces the principle that an honest day's work should be rewarded by an honest day's pay. The other policy that we have that gets at this is the earned income tax credit, and that's also being proposed by the Biden administration to be expanded. Another Biden proposal that's currently being talked about is the administration's infrastructure plan. So part of that infrastructure plan is the idea of investing in bridges and roads and things like that. But another aspect of it is to create good paying jobs through the development of green technology and placing an emphasis on improving the social infrastructure of low-income Americans. So this would include investing in upgrading the country's housing stock, modernizing public schools, and opening up access to good quality childcare. And the United States is clearly an outlier among the industrialized nations when it comes to providing these essential social goods for all of its citizens. So in recognizing the importance of the social infrastructure, the Biden administration is again redirecting federal resources to attack the structural failings found in today's society. So to kind of wrap up here, taken as a whole, I think it's extremely encouraging to see a presidential administration at last proposing a range of policies designed to rectify the structural nature of poverty and inequality. Rather than simply focusing on who loses out at the game, the current administration is looking to address some of the root causes as to why the game produces losers in the first place. So with that, I'll draw my discussion to a close by noting that if there is a silver lining behind the current pandemic in the United States, it's that it has caused us to reevaluate both the causes and the solutions to poverty. The pandemic has dramatically shown that poverty tends to be the result of structural failings, and that solutions to poverty must address those structural failures in order to be effective. So I will end my comments there, and I will turn it back to Li Chen to continue on.
Thank you so much for Professor Rank's presentation on the poverty issue under a pandemic. I think people would feel like the comments are really stimulating to think. The second presenter I want to introduce is a good friend of mine. It's Professor Julian Cho, who is the professor of Berkeley University. And he's going to present the issues for the low pay for the Asian American in America under the pandemic period. So how about, where's the Professor Cho? Oh, here, okay, good. I give the time to you.
Thank you, Li Jian. Can you all hear me?
Yeah.
Okay, great. Well, thank you so much for inviting me to speak here in California, 6,500 miles away, and because of the pandemic. All right, so I will need to use my PowerPoint. So if you can give me privilege to share my screen. Okay, can you see the share screen? Okay, now I'm not too familiar actually with graphics, but anyway. So on the screen, you should see my title of my talk, right? Asian Pacific American low-wage workers during the pandemic and beyond, correct? Is that right? Okay, so I will keep going then. All right, so originally when Li Chen invited me to share my research with the group in early summer, and I thought I would be able to collect some primary data on a study that at that time I thought I would be doing, but because of the pandemic again, it was a little bit hold back. So instead for today, and I'll be able to not focus so much on the finding of the study. I will tell you a little bit on what I might going to do, but I would like to share the story with you. As we all know, as of yesterday, I found out over 700,000 lives has already been lost, and more than 45 million cases has been reported, right, with COVID in the United States. So for the majority of the people, yes, we live in the pandemic, and it will be difficult for anyone to live in the pandemic. But as a member of an Asian American, it is even more difficult because we face a dual pandemic. One, for the coronavirus, and certainly another one for anti-Asian racism. So what I would like to share with you for the next 15 minutes or so is the triple crisis facing Asian American and Pacific Islander in the United States. The anti-Asian racism, discrimination, challenge with our health and mental health, and the economic hardships that Mark has talked about earlier and clearly lay out the context for us. Then I will tell you a little bit about some possible solutions on all these three aspects and challenges facing Asian American. So we say we're going to deal with a dual pandemic. In 2015, the World Health Organization wrote, right, disease name really do matters. We have seen certain disease name provoke a backlash against members of particular religious or ethnic communities. On February 24th, 2020, WHO said, don't attach location or ethnicity to the disease. This is not a Wuhan virus, Chinese virus, or Asian virus. And you know what? On March 16, 2020, the former US president tweeted with the phrase Chinese virus. Well, our politician might want us to believe there's nothing wrong to use name, coronavirus, a Chinese virus, Wuhan virus, whatever, and it has nothing to do with racism. But the evidence shows otherwise. A recent study showed there's strong empirical evidence that words do matter. Analyzing Twitter hashtags 1 week before and after the ex-president's tweet, a 30% point differences on anti-Asian hashtag was found between all of the neutral term COVID-19 as opposed to Chinese virus. Some of the hassle, hatred words are simply too painful for me to even say or show them here. So those of you who are interested in reading more about it, go take a look at the article. So not surprisingly then, we see a big jump on anti-Asian hate crime, while overall hate crime drops during the pandemic. We have an increase of over or up 149%. Some of the common type of hate crime against Asian Americans on a daily basis, primarily verbal harassment, avoidance, and even physical attack. Since the pandemic, Asian Americans experienced hate and have been consistently living in fear. 8 in 10 Asian Americans in this particular survey say violence against them in the United States is increasing. 45% of the respondents say either themselves or one of the close members or they know someone who's been the target or the victim of hate crime. It's an ongoing fear. So during the Delta variant, a higher proportion of Asian American report they have fear someone might threaten or physically attack them because of their race and ethnicity. Indeed, here's another survey. 8 out of 10 Asian American respondents indicate life has changed, which will never be the same again. And here, over half of the respondents aged 18 to 34 report there's a worsening mental health conditions. But with respect to vaccination, we have some good news. Asian Americans have the highest vaccination rate. So as of October this year, almost 7 out of 10 Asian Americans have received at least 1 dose of COVID-19 vaccine. But where unfortunately, Hispanic and Black are falling behind. But despite a higher vaccination rate, there has been excess death, especially during the early stage of the pandemic and among some Asian American subgroups. So at the local level, we see some groups, like for example, Pacific Islander, okay, and in some cases, Filipino Americans and Southeast Asian have a higher death rate from COVID than the larger Asian American as a whole group. So it is important for us to be able to break down the data as in order to recognize and understand some of the subgroups who are most vulnerable during COVID-19. Then another important impact of the pandemic on Asian Americans is we're suffering from worsening mental health. For example, in this particular survey, they're jumping from about 10% in previous years in 2019, now to almost 41% are experiencing anxiety and depression. And obviously, for those who face anti-Asian discrimination are much more likely, or twice as likely, to report they are having depression or anxiety symptoms than those who did not face discrimination. And by the way, I have yet to find one of my colleagues or friends who belongs to the latter group, those who did not face discrimination. As you all know, even Jeremy Lin is no exception. 林书豪. However, despite the growing needs, we see there is a lack of culturally responsive mental health services, an area that we must be better addressed. Many of these issues actually have to be understood under this larger context of how it's related to poverty. Because most of the Asian American, okay, especially those who work in the low-skill, lower wages worker, face extreme economic hardship. They're being unemployed for a longer period of time during the entire pandemic, an issue that Mark has mentioned earlier. But for Asian American in particular, they also face a higher displacement rate compared to other ethnic racial groups. In the same time, they also have lower re-entry rate. So only 54%, okay, able to regain employment. Well, a large proportion of Asian Americans, they are business owners. So the difficulty, the challenges they face are no exception. In one survey here, in New York City, more than half of Asian American business owners report they lost over or more than 75% of their revenue during the pandemic. A more recent study in Southern California and Los Angeles, same thing. Okay, a much higher proportion of Asian American compared to the entire California small business as a whole, okay, report they have large negative effect on their business. And many of them, they are unable or they face particular barriers to apply or receive assistance. And many of them did not receive any assistance at all. Just the application process, it might be out of reach for many of these smaller Asian American business owners. At the same time, okay, despite all the difficulties that I have actually documented and mentioned to you earlier, due to the common myth or belief that Asian Americans as a whole or as a group are the model minorities. They don't have problems. And even though they have, they can take good care of themselves. So Asian American has largely been invisible on the philanthropy and foundation funding sources. So here, a study found in 2018, as recently as 2018, only 20 cents out of $100 of foundation funding serve Asian American interests. Okay, so not even $1, 20 cents out of 100. So to change the course of action, there's a group of Asian American leaders across the United States formed the Asian American Foundation in early 2021. So borrowing from Andrea Ritchie's award-winning book title, Invisible No More, less than 1 month after launch, the Asian American Foundation, they raised over $1.1 billion to support the Asian American and Pacific Islander community. So less than 1 month. And we see many, many more anti-hate rallies and protests all across the US. Asian is not a virus. Racism is. There is one outside of San Francisco Civil Center. And Stop AAPI Hate is a nonprofit organization that runs the Stop AAPI Hate Reporting Center. It was originally formed in 2020. So now, Time Magazine has named their 3 co-owners to be the 100 most influential person in the world. Here, 4 decades ago in Detroit, a 27-year-old Chinese American, Vincent Chin, was beaten to death because he was seen as a Japanese who was responsible for taking American auto workers' jobs. 4 decades later, earlier this year in San Francisco, an 84-year-old white American who was originally from Thailand, Uncle Richard Watanabe B, was slammed to the ground senselessly and died 2 days later, as he was seen as someone who was responsible for COVID. Here is a mural. It's dedicated to honor his life. And we see more community organizing and support across the United States. Volunteer in Oakland provide chaperone and escort against anti-Asian bias by scheduling or walking with some of the most vulnerable neighbors, by older adults and women, the 2 groups that have been particularly attacked. We also see more community support. Here, famous actually chef, Tim Ma, Kevin Tin, Shirley Jones, among others. And they put the chef stopping AAPI hate, so you can take out actually a 5-course order from participant restaurant to raise funds to stop Asian American and Pacific Islanders hate. And I believe now they are running this in New York City, LA, San Francisco, and 2 other cities. And some of these community support or activism did not really happen until the pandemic. In the meantime, we see many, many nonprofit organizations, because now we are getting actually more attention and more funding. We are no longer invisible, and we're getting more support to provide the necessary resources to, for example, provide public education and advocacy, and translate some of the application materials into multiple languages, and using text messages, app, and other technology innovative device to reach out to the more isolated communities. But despite all these efforts, certainly more needs to be done. Mark has mentioned earlier at the federal level. But at the local level, we also see the community-based projects and initiatives coming out almost everywhere in large Asian American and Pacific Islander communities as well as smaller cities all across the US. Here is one of the projects that I actually started, and that was originally the one when Li Jian asked me to share some of the findings of this particular study, but I have not been able actually to get it off the ground, is really trying to look at the solidarity and community economy. So we are looking at worker-owned cooperative as a possible and viable alternative to work after the pandemic. And here, this is a study by the UC Berkeley Labor Center, particularly show that women make up a disproportionate share of low-wage workers, especially among Asian Americans. So they are the ones actually that's much more vulnerable, and in terms of, again, losing the livelihood during the pandemic and do not really know what will be the futurity. And here, and we would like to explore this particular issue and to what extent they will be able to provide more say, put the employment opportunities back to the hand of the worker. And finally, just would like to share my team members. Without their support, the project would not be possible. And thank you for all of your attention. In solidarity and community, invisible no more.
Thank you, Professor Julian Cho. The presentation is really rich, show a lot of rich information on the Asian American life there. And now going to the third session, a third presentation is presented by me. So I will be the moderator and presenter at the same time. Okay, thank you. Thank you for the PPT. Let me take out the mask. I think we are in a secure social distancing. Okay, I will turn the topic to the how the homeless service network responding the pandemic impact on the homeless people. Okay, it's not moving. Okay, I got it. Just slow. Okay, I think less than 3,000 outdoor sleepers per year receiving social service from the government. So these are the chart of the yearly development. There has been high and low, but it's always under 3,000 people. There's been one time it's really high, but it's only the official figure on receiving social service from the government. It should be underestimated. And I think everyone knows on early May, an unexpected outbreak of COVID-19 happened at Wanghua district of Taipei City, where many outdoor sleepers encamped around at a park in the center of the district. It's very slow. Okay. there's been estimate about 200 outdoor sleeper in camp at the Mongjia Park in the district. Actually, 14 out of 169 tested and confirmed as positive infection. And as we know that the government has already adopted the maintaining social distance and lockdown as an effective measure to stop the spread of the virus. However, sorry, I think it's the machine does not get along with me very well. 它是不能往上一点。OK 了 ，OK。Okay. So, however, these two measures actually disrupting the living on the street among these outdoor sleepers. There are several negative impacts were observed. The first one is at food level, security level. And the outdoor sleepers are unable to find sufficient and nutritious food in the neighborhood because of the lockdown of the temples, which has been major, food supply for these people. And the second thing is that they are unable to find odd jobs to earn money to buy food. And the second negative impact is on their health security. And the outdoor sleepers cannot maintain personal hygiene because they don't have enough. They don't have access to the masks, soaps, tissues. Several cleaning stations were closed at that time. And they also, for those people who are tested as a positive infection, lack of isolated places for them to do quarantine and aftercare housing. And the third negative impact is the community stigmatization. I think Professor Cho showed how Asian American got stigmatized under the pandemic, but the homeless in Taipei is also experienced the same thing. Because I think their wandering lifestyle was considered as high risk of virus transmission. And also they had the meal outdoor. They can't have to have meal outdoor. That without mask on, and also they look so dirty and the mask also very dirty. So creates the community panic. And at the same time, I think the reason for that is I think the media actually took the picture of them, showing in the newspaper, so people got panic. And so the public urged the government to kind of provide the placement for them, keep the community safe. Also, they even asked the police to kind of just drove them away from the park. So but at the time, not a shelter open for the outdoor sleeper at that time. Police would encourage the clear encampment to avoid virus transmission. So how the Homeless Service Agency responded to this crisis, and the Homeless Service Agency used to be very small scale, with very understaffed and less resources. So it is a necessary and a smart way to kind of organize together and collectively together to provide the services. So, and also the workloading increased because of the pandemic. So this agency actually got together at the time and to come up with a collaborative plan to food supply and health promotion for the outdoor sleepers. They set up a fixed time frame for the food supply, so they can pack up the food pack up the dry food in a pack and to deliver at a fixed places. At the same time, to secure to keep the secure place, so the virus could be contained. And also they will provide assistance together and efficiently. They also created a united way of fundraising. There's a newspaper, free news reporter, write some article on it, and they collect quite a few funds to have the service run at a time. So this collaborative network set up food supply stations for the homeless as needy service entrance. When people come, so they can check on them and to ask them to get a test. And they also advocate and manage a few isolated houses for people when they need quarantine and aftercare. They also collaborated with health department, self-service for virus testing, and also arrange the hospitalization. So since the COVID-19 is not going to cease in the near future, I think this presentation calls for some preventive measures for the government. First, I think for the unexpected outbreak will come in the future, I think the government should providing support for people, personal protective products, and the food supply for them, so they can survive. And the second thing is advocate for preparing isolated housing for people with quarantine need and aftercare. I think because the housing is really expensive kind of social services. So for this small collateral network, they actually squeeze all the space they can to shelter these people. So hopefully in the future, government will have this kind of housing supply for these people in need. I think I remember on the SARS time, Taipei city government actually cleaned how's that? It's a military bunker. So they can empty the bunker and then prepare for the housing facility. So ask the homeless to move in to stop them to wandering around. So, but this time they didn't do it. I don't know why. But then the third thing is building collaborative networks during ordinary days as well as the outbreak time. Because I think this time, in this May outbreak, this collaborative network actually really function well and provide enough services for these people to have the food and and the health got promoted. Okay, this is my presentation, kind of share what the observation that I have with those homeless social service agencies, and how they using a very small scale kind of collaboration to fulfill the service delivery to those people who sleep outdoors. Okay, thank you. And thank you. And the fourth presentation was the Professor Lee, who is also my student. So with Mark, and the first generation, and me are the Mark student, and then Lee is my student, so there will be 3 generations here. And Professor Lee is the expert on the employment policies for the poor people. So that's here, the topic.
Thank you.
Thank you for Professor Zhen's introducing. I'm really nervous to have a short speak after 3 master. Okay, good morning, professors and ladies and gentlemen. My name is Jingling Li, and I'm currently an assistant professor at Mingchuan University. It's a great pleasure for me to be able to attend this conference. Today, I'm going to share my observation with you. My topic is employment for the economically disadvantaged during the pandemic. Okay, first, I'd like to share some data about the labor market during the COVID-19 pandemic in 2021. Regarding the situation of the unemployed, according to the government report, the unemployment rate in June this year was 4.8%, was continuous rise in the past few months. Moreover, in July, the number of people who were first recognized for the verification of unemployment benefit reached more than 10,000 workers. In total number of unemployed was 570,000. It's a huge increase compared to the same period in previous years, and reaching a new high since 2010. About the reduction of working hours and unpaid leave part, both employers and employees, they negotiate to reduce working hours, which we call unpaid leave, has affected nearly 59,000 workers and more than 4,800 manufacturers in August. Furthermore, considering working less than 35 hours per week, which means less than 5 days per week, the number of workers in this situation has exceeded the previous years. After pandemic in May, the number of workers reached 776,000 in June, which is several times more than the number of people who reported the agreement to reduce working hours. And in the following, let's take a look to see the impact of disadvantaged workers. There are 144,000 workers are unemployed due to business contraction or closure of the workplace. Unemployment was concentrated in support services, accommodation and catering, wholesales and retail sectors. Workers in services sectors that require interpersonal contact have been hit hardly, and workers in low-paid industries are also valuable, while the employment of workers in high-paid industries is relatively unaffected. The growth and decline of labor population statistics about reducing working hours unemployed and withdrawal from the labor market tell us more. The number of workers with reduced working hours increased rapidly at the beginning, accounting for more than 80%. But since August this year, after the pandemic has slowed down, the number has decreased rapidly, and the proportion has also fallen below 50%. In contrast, the number of unemployed and withdrawal from the labor market increased slowly at first. However, it increased gradually, even the pandemic slowed down. The combined proportion of these two in total affect workers was only 17% in March in 2020. However, this year, in August, it's reached 29%. And moreover, it's reached 42% in October this year. Moreover, according to a report released from World Economic Forum in October, it says the rise of machines and automation may make 85 million jobs disappear by 2025. So it says that automation and pandemic have a double blow to disadvantaged workers, causing increasing inequality. In the face of many full-time workers become part-time workers or even unemployed, the government has proposed many solutions to solve their current difficulties. In helping the workers' part, those who meet qualification of the labor insurance system provide unemployed benefit. Helping workers to reduce pressure on loan, provide interest subsidies. Helping workers with unpaid leave or reduced working hours, provide subsidy for salary and job training. And also creating great amount of short-term job opportunities in the public sectors. Moreover, if the worker finds a job and has a stable employment, then they can get employment incentive allowance. And in terms of helping employers, it provides company hiring incentives. Then we can see that though the government has provided many subsidies in response to the impact of the shock of the labor market, the development of working abilities is more important for those low-paid, low-skilled, disadvantaged workers to avoid falling into a longer-term unemployment dilemma. The following are some strategies of the San Francisco Human Services Department in assisting disadvantaged workers, which can be used as a reference for us. From the perspective of employment supply, enhance the working ability of disadvantaged workers, including develop employment-oriented job training. Then the workers can have jobs directly after training. Helping workers with low working ability to gradually develop employment skills, starting from a protective environment and improving in stages. And in response to the digital age, enhance digital skills in working abilities. In providing employer hiring incentives, not only government directly provide salary subsidies to employers, but also allowing disadvantaged workers to find their own job with employment vouchers to expand companies willing to hire this kind of workers. Moreover, since these families are more economically fragile, though the helping strategy should focus on building their workforce development and working abilities, research also shows that it is important for them to include the social services support, such as child care support, physical and mental health support, transportation assistance, and maybe other necessary social services that are necessary for low-income households to attain their education or job or career goals, as well as balancing working and family, and help them gradually toward economic self-reliance. This is my presentation. Thank you for your listening.
Thank you for the 4 presenters. All indicate some of the poverty-related issues on the pandemic period. So we have only 3 minutes left. Any question for 4 of us? Okay. There are some questions. Thank you. I think the question is about Asian America. It's to the Professor Cho. The question is, and the hostility demonstrated to Asians due to a long-term hidden sentiment existing even before the pandemic, but was heightened versus China because of pandemic. Is this the question? I'm not sure. I think it's asking is the stigma and hostility demonstrated to Asians is long before. Is that a question to Professor Cho? Can you answer this?
Yeah. Can you hear me, Li Chen?
Yes, please.
Oh, yeah. Well, thank you for the question. Yes, I believe so. As we all know, the first time ever immigrant law in the United States is 1882, the Chinese Exclusion Act. This is the first ever immigrant or immigration law. And then during the Second World War, right, Japanese Americans, even they are U.S. citizens who were born in the United States, and many of whom even actually served in the military to fight for America during the Second World War. Their family members were being interned. So over the years, over the past actually, century or two, Asian as a group has always been a target by the U.S. historically. So the pandemic perhaps is just, again, it's just another scapegoat for the frustration, the difficulties, and also being played out by some of the politicians. So a short answer is yes, it has historically, Asian has been targeted for xenophobia in the United States.
Yeah. Thank you. Yes, the pandemic actually devastated the stigmatizing. Do we have another question here? Okay. Since there's no more questions, so how about we end the session here? Thank you for Mark, Julian, and Jingling to help me complete this session. Thank you. Bye-bye.
Thank you, Li Chen.
Distinguished guests, ladies and gentlemen, thank you for your participation. We are going to conclude the session here. We hope you have a wonderful takeaway from this session. We'll now break for lunch. Please follow our stop to the designated dining area. The forum will resume at 1:30 for parallel sessions 6, 8, and 10. Please head to the location accordingly. Online guests will be able to find the link to parallel sessions 6, 8, and 10 on the forum homepage. Thank you.
To parallel session 8 of the 2021 Global Health and Welfare Forum in Taiwan. In this session on health workforce and people-oriented care, hosted by the Department of Medical Affairs, Ministry of Health and Welfare, we have the honor to invite Dr. Liu Yueping, Director General of the Department of Medical Affairs, as our moderator today. Please welcome Dr. Liu.
Good afternoon, ladies and gentlemen. Today we have lots of guests from online and on-site attending this forum with us. And first, on behalf of Ministry of Health and Welfare, I would like to extend our sincere welcome and gratitude to all attending experts, scholars, and partners who are concerned of healthcare, human resource, and human-centered care topics. Welcome to the 8th parallel section of 2021 Global Health and Welfare Forum in Taiwan, held by the Ministry of Health and Welfare. This section involves things related to healthcare personnel education and sustainable management of healthcare systems. As the Ministry of Health and Welfare has promoted competence-based medical education and hospital accreditation systems reform, we held this forum and invited keynote speakers from home and abroad, such as Australia and America, to share their experience. The theme of the parallel section is healthcare, human resource, and human-centered care. The two topics of healthcare personnel education and sustainable management of healthcare systems are addressed. Because of the pandemic, the forum is held online and offline concurrently. Joint discussion of all attendants and online viewers from all over the world is encouraged. I will briefly introduce the distinguished speakers. The first one will be the Chief Deputy Superintendent Lin Hongrong. I think I freely speak in Mandarin, so I just introduce Lin Hongrong. And of Qimei Medical Center, he will share the experience about the pandemic for the sustainable management of hospital in the post-pandemic era. And the second one will be the Professor Jeffrey Braithwaite of Macquarie University in Australia. He will talk about sustainable management of healthcare to broaden the vision of healthcare sustainable management to the global level. He also is known as the president of ISCRA. I think many of our attendants, our guests will know him as the president of ISCRA. The third one will be the President Lin Qizhen. He is the president of Joint Commission of Taiwan. He will share the experience of cultivation of healthcare personnel in Taiwan. The first one is the Chief Researcher, Milestone Development and Evaluation Officer of Accreditational Council for Graduate Medical Education in America, Eric Homo. He will give us a lecture on key problems of post-pandemic professional education of health. Let's begin this afternoon's section. Thank you.
Lin Hongrong 副院长。
Thank you, our chair lady. Thank you for your kindness introduction.
Ladies and gentlemen, good afternoon. It is my honor to give a speech to talk about hospital sustainability in the post-pandemic era. Okay. Conventionally, we talk about sustainability. That means the balance between the environment, the economics, and our society. I will use my hospital as an example. I work in the hospital, which is called Chimei Medical Center. It belongs to a hospital group in Tainan City. We have 3 hospitals in our group. The highest medical center and regional hospital and district hospital, we have 3 levels of hospital. And our hospital work hard in order to fulfill our society responsibility. We emphasize the environmental protection heavily. In last year, 2 hospitals in our group won the silver awards, the Enterprise and Environmental Protection Award from Xingzhengyuan. That means that we work very hard to do that. For example, this is the Liuying Chimei Hospital. This hospital is a unique hospital. It is the only hospital larger than 500 beds, but there is only 6-story high. That means that it is an eco-friendly hospital. We emphasize the eco-friendly everywhere in the hospital. But in our hospital, we still encounter environmental issues. So green hospital is not enough to handle all these problems. In the year of 2009, Typhoon Morakot attacked Taiwan. Heavy rainfalls were encountered, and the roads near the hospital were flooded, and the hospital was isolated temporarily. So environmental hazard could hinder the hospital operations. At the same time, in the same typhoon, in our another hospital, our Yongkang Chimei Hospital, we encountered another problem. We have a water supply shortage for 78 hours. So it is ridiculous. There is heavy rainfall outside, but there is no water inside the hospital. It is because of the turbid reservoir in Tainan. So we must know that business continuity is an important issue. We must try very hard in order to protect the hospital continuity, in order to keep the hospital operate. This year, we have the water shortage again, but it is due to the drought. So the hospital could be the victims of climate change. In this year, we launched our water rationing plan in order to reserve more water. So, talking about sustainability, there is environmental issues, there is society issues, but there is another domain that we have to notice, that is the operational risk, especially in the pandemic. In recent 2 years, we encountered the COVID-19 crisis. There are many countries that had a severe COVID-19 infections. Their healthcare system faces the risk of collapse. Even in the United States, they have to recruit volunteers from all over the country in order to fill the gap of manpower shortage. So COVID-19 is a wake-up call. Are our systems sustainable? Not only environmental, but there is also many aspects that we have to pay attention to. The first one is the waste related. We produce large amount of waste, PPE, mask. That is a severe problem after the pandemic. we have the burnout issues of our employee. We have manpower shortage. We have supply chain disturbance. We have financial issues. And from the aspect of public health, many patients delay their treatment, especially the non-communicable diseases. And the health inequity also worsened in recent 2 years. So COVID-19 is a severe pandemic. And we learned 2 things in this pandemic. The first one is that we must have resilience. The system must be resilient, and our personnel must be resilient. A conceptual framework was proposed by Mr. Olu. That is called the resilient healthcare system. And there are 6 domains that we have to pay attention to. The first one is leadership and governance. The second one is information and the healthcare workforce, financing, medical products, and service delivery. I won't go through details in 6 domains. But in order to make a resilient healthcare system, we must work hard in all 6 domains. In the time of pandemic, we must make quick responses in order to cooperate with the situation change. So the hospital must be agile, and agility management could make the hospital make quick responses in time. I take one example, that is our information system. We built a fever map system. We revolutionize the system frequently in order to screen out infectious patients in our system. This is another example. We revise our visitor management frequently in order to cope with the situation. As you can see, in 1 year, we make many responses. We make many decisions in order to cope with the COVID-19. So, from the Ministry of Health and Welfare, this year, the 9th Medical Care Network Plan was launched. The title is, we have to build an agile, resilient healthcare system. So I think the 2 lessons we learned in this pandemic was compatible with the title. And in order to cope with the future crisis, we have to be agile and we have to be resilient. If we look further into the post-pandemic era, we shall see what we already learned. This is the hospital in China. This is the largest hospital in China in Asia. 郑州大学第一附设医院. This hospital, it owns 10,000 beds. Is such a mega hospital sustainable in the future? We should think about it. Even societal, even environmental. Of course, the first one, we have to pay attention to the building, to the architecture. The architecture should be green. The green building can save energy, can reduce waste. But we can see the problem from a broader view. We can see the problem from a larger scope. This example is from Singapore. This is a brand new medical campus, which is called Woodlands Health Campus in Singapore. It will be launched in 2023. As you can see, there is no more mega building. There is no more mega hospital. Instead, they split the hospital into several parts. The first one is a high-level acute hospital. The second is a community hospital. But the hospitals could be connected and integrated. And there is a long-term care facility, and there is a specialist outpatient clinic. So, so the building could be separated and integrated at the same time. And the structure will be decentralized. The design will be decentralized. No more a mega hospital. The economists predict, they say that the hospital will be thinner, just like an airport tower. What does it mean? How can the hospital be thinner, be smaller, but do much more things? There are two development trends. The first one is home medical care. If patients stay at home medical care can reduce unnecessary admissions. The second one is telemedicine. Telemedicine let the medical personnel in the hospital, they can monitor patients at home. And the patients and the families could communicate with doctors in the hospital. So combine these things, there will be a hospital at home model. And the hospital at home model will bring hospital level care to the patients. And if we combine telemedicine and home medical care, there will be a new model. The new model from the commercial term, that is online to offline model, O2O model. So we can use such a model to make the hospital thinner. And further, we can think, other than disease management, can hospital do anything else? If you see the title, the hospital manager will think that it is a nightmare. Hospital is gone, but people are getting better. So that is healthcare promotion, health promotion. So we have to redesign our hospital, redesign our healthcare system. The hospital must adopt the role of health promotion. That could make the healthcare thinner and greener. My brief conclusion is that post-COVID, there will be new issues on hospital sustainability, environmental, societal, and economic issues. And facing future challenges, agility plus resilience would be the essence of hospital sustainability. And the O2O model, the telemedicine plus home medical care, will make hospital thinner, make hospital greener. And thinner hospital and health promotion will make healthcare system more sustainable. Thank you for your listening.
谢谢林鸿荣副院长。Thanks, Dr. Hongzhen Lin, for the informative speech.
Thanks, Superintendent tells us about how to react to the to be a agile and resilient healthcare system. And I would like to introduce the second speaker, Professor Jeffrey. Okay, because there is some technical problem about Jeffrey, so I think I would like to ask President Lin Qizhen to give our second talk. He will talk about the medical education of health personnel in Taiwan. He will share the experience. Let's welcome Professor Lin.
Dear Chair, distinguished guests, ladies and gentlemen, on behalf of Joint Commission Taiwan, I'm honored to be invited to talk about the education of medical workforce. Of course, I will emphasize the small changes and to look if the preparedness of medical staff will benefit from the minor changes. We all know that medical education in Taiwan started from National Taiwan University since 1897. At that time, it was Japanese era, so the medical system and educational system is called Japanese style, Nihon Shiji. But after World War II, there are 12 medical schools joined NTU year by year to train medical professionals. So there are an overall number of 13 medical schools in Taiwan right now. First, we are quite confident in our training program or educational program, and we are very satisfied with the result of education. Either for 7-year curriculum for the physician, or it is a 5-year postgraduate curriculum. Because since 1984, there are 4 medical schools trying to adopt the postgraduate curriculum in Taiwan. But due to several reasons, not listed or discussed today, there are only 1 remains. And after medical school, most of the doctors will go into the professional training. And most of them, if want to stay in a medical center or big hospital, they will usually travel abroad to become clinical staff for at least 1 year. So we are quite confident in the quality as well as the quantity of medical staffs. Unfortunately, SARS outbreak attacked Taiwan in 2003. Suddenly, we found there are many victims. They are not heroes for medical staffs. And we realized that something was missing in a map of the full spectrum of medical education. We reflected that SARS is not only a great challenge to humanity, but also even a greater challenge to medical system, including for the medical educational system. And we reflected that jumping from medical school to professional training is probably too early. And the training of general medicine practice is still inadequate. And facility and the trainers need to be increased, and the teaching skill and experience are still not sufficient. Consequently, Minister of Health and Welfare in Taiwan began to design the PGY training program and conducted by the Joint Commission of Taiwan. The training process is to increase a period of postgraduate year training between the medical school and the specialist training. For the training, we will emphasize for the core competence of 6 issues, including patient care, medical knowledge, practice-based learning and improvement, interpersonal and communication skills, professionalism, and the system-based practice. In order to make sure that the 6 core competences can be taught and learned, we emphasized on the manpower, on the improved curriculum, we focus on the faculty, and we revise the evaluation system. That's the reason why we can connect the UGY to the specialist training with PGY in all 6 core competences. At first, such a PGY program is designed only for the physicians. So in 2003, it is a 3-month program only. And in 2006, it became 6 months program. And in 2011, it became a whole year PGY program. At that time, medical school is 7 years, PGY is 1 year. So it is called 7+1 program. But in 2019, the PGY became 2 years, and the medical school was reduced from 7 to 6 years. It was called 6+2 program at that time. Of course, the major change is to change the original internship, the year, to become another year of PGY year. I think it is a very important issue because for the first year of PGY, it is rotate training. It goes to every specialty to learn something. It's to learn something of everything. But however, in the second year of PGY, we divided them into groups, 5 groups, including general internal medicine, general surgery, general pediatric, general OBGYN, and interdisciplinary. And after the 2-year training, they can go into the specialist training. However, how can they really connect? And is there any parameters that could be ensure the success? I think that is the most important issue. And we also adapt a system. If he chooses the PGY in the internal medicine, then he chooses the specialist as also internal medicine. If we can make sure their core competence or the other things such as milestone PGY are adequate, then they can become the second year of residency. If not, if go to another group, then he or she must start from the first year of residency. At first, it is only designed for the physician. But however, after the success for the physician, other healthcare professionals decide to join or add PGY program into their specialist training. So there are many other healthcare professionals gradually adopt PGY in their training. Of course, most importantly, nursing. Here we have a lot of specialist mentors here. Traditional Chinese medicine, dentistry, pharmacy, nursing, medical radiation, medical testing, respiratory therapy, nutriology, OT, PT, clinical psychology, counseling psychology, speech therapy, audiology, midwifery, and then dental technology. All of them decide voluntarily to join the PGY program. Of course, for such a program, quality improvement is very important. So we set testing, teaching, effectiveness indicators. We have to conduct on-site investigation and the consultations. We do workshops of benchmarking. We do faculty development, questionnaire for trainer and trainee, and teaching hospital accreditation criteria. It will become accredited when they have to be accredited. An overview to the training program. For the physicians is the chart above. There are so many hospitals and courses established. And for other professional, healthcare professionals, there are so many training hospitals and courses. In general, there are about 27 or 28,000 trainees per year in all the medical health professions. And the questionnaire for the PGY trainee and the trainer, they answered they are willing to support the PGY program for about 85%. And if they are asked if their clinical skill have improved, almost 90% answer yes. I think it is something because not only trainee, but also the trainer, they are confident of their clinical skills after the training. It means that the preparedness of all medical staff have increased. And this is the faculty development numbers. There are so many staff involved here. And then we have published a lot of textbooks, materials, platforms for everybody to join and to share. However, nothing is without challenges, especially when we talk about from this stage to another stage. How can we be sure that they are well equipped with knowledge and skill? I think it is important to continue to achieve the model of competence-based medical education, especially when we learn from other countries, especially the United States. Thanks to Professor Eric Hombo. He has been to Taiwan for many times for teaching us about the issue of competence-based medical education, the milestone, the EPA and trustable professional activities, and how to localize and how to evaluate. There are also other challenges. For instance, the working hours of PGY and resident are protected or restricted in the Labor Standard Act since 2019 in Taiwan. Then, balance for clinical training and effect, as well as the working hour, should be balanced. It's an important issue. But however, during the delivery time, we have to make sure that are well trained, that based on the competence-based medical education and the EPAs. And also we have to face with the next generation for the important issue. For instance, the aging. Integrated care is important. Artificial intelligence or telemedicine, as just said, or the 4P medicine, with prediction, prevention. We have to personalize and we have to be participative. And the precision medicine, they are all challenges. So we have many innovative things to teach or to learn in a training program. And if you want to look at the success or not in such a small changes in the medical educational system, we have to say that our purpose to make all the medical staff more human. There is a saying that before becoming a doctor, become a man. But not necessarily they have to become a patient. Because if for more understanding, there are many ways. So that's the reason why I have to talk about the shared decision making. The shared decision making is to teach the patient as a student, because there are always knowledge gap between the medical staff and the patient. So for the communication, the physician or healthcare practitioner have to teach what they know and ask the patient to talk about their preference, choices, and then they have to decide. In order to do that, the physician have to use their knowledge, especially the evidence-based knowledge, and to tell them what is the pros and cons of the options. And then we ask the patient to talk about the expectations, concern, and preferences in order to make the right decision. In the teaching process to the patient, we must use PDAs, including worksheets, videos. And when we can talk to the patient, we use the 3-talk program. The choices talk, the option talk, and then the decision talk. All the shared approach in order for the patient to consider and then to do the correct or optimal patient care choices. And we are greatly to know that shared decision making in Taiwan is not only an exercise, but even it has become an intrinsic culture in medical system. We are proud to say. So, and for the PDAs, for the government funded, are so many. And all of them can be shared in the platform. So everybody can share the experiences or what they have learned from other conditions. And then we call for hospital to implement the SDM. And even their success or efforts will be credited in the hospital accreditation. And we also do the public promotion. We ask the patient and the family to be aware of advantages and the disadvantages of each options. We ask them to think about the considerations and their preferences. And the patient and family have to talk about their expectations and the most concerned issues. Then, after such a good communication, the optimal choices have been done, then the doctor-patient relationship will be better. The doctor will become more human, and the patient will be more satisfied. So, in such case, we believe that the promotion of education of the medical workforce is to increase the preparedness of all medical staff. And such a preparedness will be lead to promotion of quality improvement activities. So that is the reason why the quality improvement and the patient safety has become a very important issue in Taiwan, and we established a Taiwan team to attend the international activities and get very much accredited. And then we have been, I have to say, very, very high. Thanks to ISQA and thanks to Jeffrey, because Jeffrey had come to Taiwan and to teach us and to encourage us for many times. So later we will listen to Jeffrey's talk. We are not sure when the pandemics of the COVID-19 will be over. We are not sure when another pandemics will come, but we are quite sure that with the preparedness of all the medical staff after the small changes in education of medical workforce, I think we are ready to face the future and with most likeliness to be successful. So let us work together for more advanced medical education and the quality improvement, because nothing can be achieved without collaborative efforts. Thank you very much.
Thanks, Dr. Lin Qizhen, for the informative speech. And we'll welcome the next speaker, Dr. Eric Homo, to talk about key issues for health professions education in post-pandemic era.
Thanks above to Dr. Lin, because they share the experience in Taiwan. Right now, let's welcome Professor Eric Homo. Eric, are you online right now?
I am. Can you hear me?
Yes, yes, very clearly.
It's great to be with you virtually. I am really disappointed I cannot be there in person, but I'm really excited to talk with all of you, and I really enjoyed the first two talks. So let me go ahead and show my slides, and we'll get started.
Okay, now it's your turn.
And can you see the slides?
I'm afraid not. I only saw you.
Oh, that's not good. It says I'm sharing this screen. Hang on. Stop sharing. Let's try this again. How about now?
Still only you.
Yeah, it says I am sharing my screen. I'm so sorry that we're having some trouble.
We can see your slide.
I'm sorry, somebody said they could?
Yes.
Okay. I don't know. It sounds like they can see them online, but they may not be able to see them in the room.
Okay, right now we got your slide.
Okay, fantastic. Thank you, everybody, for your patience. I'm going to just cover a couple things here and actually going to build on, I think, the talks that you just heard of. And thank you for the kind shout out in the previous presentation. But I'm going to talk about accelerating implementation of an outcomes-based approach to medical education post-pandemic. And as we just heard, not 100% clear when that's going to be, but we've certainly learned a lot already, and we've heard about some of those lessons. One of the things that we've certainly seen in the United States, and I've heard from my international colleagues, is this kind of universal conclusion that managing educational programs and determining the competence of learners during this pandemic would have been a lot easier were the medical education system in the United States further along in implementing outcomes-based medical education. The reason for this sentiment is that we have relied very heavily on what we call proxies. If I spend a certain time in training, if I get exposure to certain experiences, such as various different units within a hospital or electives, that'll serve as the outcome. And obviously that's been terribly disrupted by the pandemic, where those type of proxies were no longer available. And so this has led to a pretty extensive reflection here in the United States and again in other parts of the world about, okay, where to next? And it's not just medical education about physicians, but as we've heard, it's also about all health professions. You know, much has changed. So I'm going to talk about three what I call must-haves moving forward. There are others, but I'm just going to emphasize these three given our limited time together. I think the first is we just have to address the persistent and pernicious effects of inequities and the lack of diversity and inclusion in medical education. And that was alluded to in the very first talk about the issue of health disparity. We do very poorly in the United States with regard to health disparities, and this has clearly been exacerbated by the pandemic. And what we've recognized is that COVID-19 has created what's known as a syndemic, where you have the intersection of various pandemics, such as health disparities and inequity collides with the pandemic of a disease, in this case, COVID-19, leading to worsening of outcomes, health disparities, and so forth. So this syndemic has been a real wake-up call for us. The second is we have to get, as I said, serious about accelerating outcomes-based medical education, but I think the way to do that would be to embrace something called the core components framework, which I will share in a moment. And then we have to empower our learners across the continuum. And one of the ways to do that is to utilize something called co-production as a philosophy and approach. I was absolutely ecstatic to see the talk on shared decision-making, where patients become our partners. And we see that as part of just really high-quality healthcare, but it also enhances outcomes and safety. So that was really nice to see. Same principles actually apply with our learners, and I'll talk about that in a moment. Let's start with the kind of first must-have of really addressing inequity. This is data from the United States that shows data around excess deaths in the early phase of the pandemic. For us, we read roughly 300,000 excess deaths that occurred between late January and the end of October in 2020, with almost 200,000 of those deaths actually attributable to COVID-19. Sadly, the largest percentage of those excess deaths occurred among people of color. In this case, Hispanic or Latina persons and Black individuals. And you can see, as highlighted in the circles here, these really awful peaks of excess mortality for those two groups. We also saw excess mortality among our Native Americans. And you'll see that for the white population, yes, there was an increase in excess mortality, but not nearly to the degree as these other ethnic groups. We also recognize that something called social vulnerability and equity exacerbated the pandemic. And so what is that? These are interesting graphs from a single county in the state of Georgia. And the darker the color in each of these areas, from social economic status, the nature of the household, the race, ethnicity, and language characteristics, and housing and transportation means that that group is at higher risk. And so every community must prepare for and respond to a hazardous event, such as a natural disaster, or in the case of the pandemic, a disease. And many of these factors, such as poverty, lack of access to transportation, crowded housing, and racism, can weaken a community's ability to prevent human suffering and financial loss in a disaster, such as a pandemic. And these factors are what we call social vulnerability. And we in medical education have to pay more attention to this. In fact, many of our educational programs and training sites are often taking care of these types of populations, and yet we don't have a full enough understanding of what this social vulnerability actually means for outcomes, inequity, and health disparities. We also know that there's some serious DEI issues, diversity, equity, and inclusion in postgraduate training. Yes, we've made progress, but this is a study published in the New England Journal by colleagues from Northwestern as part of the study of surgical training in the United States. And the results are pretty sobering. This is a very well done survey that was distributed at the end of an in-training examination, and you can see that captured 99% of all residents training in general surgery in the United States from our 262 surgical residency programs. And what they found, that 32% of surgical residents reported discrimination based on their self-identified gender. 17% reported racial discrimination. 30% reported verbal or physical abuse or both. And 10% reported sexual harassment. So this is really concerning. And this mistreatment, as you can see, not only occurs frequently, especially among women, but is also associated with increased rates of burnout and suicidal ideation. I don't think that's what we want our training programs, the kind of environments we want them to be creating. So at some point, we have to become much more intolerant of this type of activity and these effects on our trainees. Unfortunately, and sometimes this often comes from patients. We have to figure out how to manage that. But sadly, a lot of it comes from faculty. So moving forward, I think we have to get serious about addressing this issue. As I mentioned, we really want to get more serious about outcomes-based education. This is a nice kind of synopsis of it from Ron Harden in University of Dundee in Scotland. And in an outcomes-based mindset, regardless of what profession you're training for, the central tenet is to start with the end in mind. You focus on what type of physician or health professional will be produced, and the structure and process of the training program must flow from those outcomes. And the educational outcomes should be clearly and unambiguously specified. And you just heard a minute ago about the 6 competencies. That's actually what helps us define those educational outcomes. And these outcomes determine the curriculum, content, organization, and timetable. And you saw in the previous presentation how the timetable, the distribution of time has changed in Taiwan, as it should. The teaching methods and strategies should flow from those outcomes or competencies, as should the assessment processes. And again, we have to attend to the learning environment. If we have a hostile learning environment, one that embraces or is tolerant, for example, of discrimination and abuse like I just showed you, that actually leads to decays in learning. Now, I mentioned the thing called the core components of competency-based medical education. This is work led by Elaine Van Mel, Queen's University in Canada. And I find this very helpful. It contains 5 components. You have to have an outcomes-based competency framework. And as I said, you just saw one earlier. There must be progressive sequencing of the competencies, because becoming a health professional is an intensely developmental process. The learning experiences must be tailored to those competencies, and our faculty have to tailor those teaching to make sure those competencies are covered. For example, the shared decision-making is a really important skill that you just heard about. And our teaching and our faculty have to support our learners to learn how to do that well. And then finally, we need a program or programmatic assessment, where we need a combination of assessments to make sure that we've achieved the outcomes we desire. So if we break these down a little bit more, here are the definitions under each of the 5 core components. Competencies are required for practice and they're clearly articulated. Second, Competencies and the developmental markers are sequenced progressively, right? And they have to be aligned with where the learner is in their development. Learning experiences facilitate the developmental acquisition of the competencies, and teaching practices promote the developmental acquisition of those competencies. And then finally, programmatic assessment using a systems thinking approach support and document the developmental acquisition of the competencies through a combination of assessment. You'll notice that in 4 of the 5 components, that word developmental shows up every time because it's that important. And we have to think more developmentally with our learners. There's also some very important philosophical principles that underlie this core component framework. It is grounded in what's called a reform or growth mindset for education that forms the basis for significantly redesigning assessment practices, instructional methods, and learning experiences. In other words, it doesn't become about the grades anymore. It really becomes about reaching an outcome, reaching mastery, truly being prepared for the next stage of your career. And it is focused on promoting learner growth and development through frequent formative assessment. In other words, low stakes assessment for the purpose of feedback and coaching. Because you need that rich feedback and coaching that has to be individualized to the learner and grounded in the desired competencies, because learners move at different rates through different competencies. And finally, to provide rich and diverse learning experiences, you must be steeped in clinical practice where learners can stay as long as required. This isn't necessarily about shortening training. It may be that for some you have to lengthen training, but time becomes a resource, and we've used as much time as necessary to achieve those desired outcomes. Now, I will not spend a lot of time on this slide, but a lot of people say, what's the evidence for this? Totally fair question. Turns out that there have been a number of important experiments around the globe that shows that a competency-based approach can actually lead to better outcomes and shortened training. But what's more important is to understand that competency-based medical education is a deeply evidence-informed approach, and that is shown by the theories that are all supported by empiric studies and science under each of the columns. And so I just want to make that point here, is that there's so much, an amalgam of theory and science that goes into this educational approach and this core components framework. So the ultimate goal of medical education for us, and I think we just saw examples of in the previous talks, is to achieve what's called the quadruple aim. Better outcomes at lower costs through improved patient experience, but also to ensure that we're attending to the experience of our clinicians. You just heard about the issues of burnout, major issues in workforce. It was highlighted that there are struggles in the United States, and that's absolutely right. We are really struggling right now. But this is the outcome that we ultimately desire. And so how do we get there? We have to integrate our curriculum and our assessment. We do that through competencies and educational outcome tools such as milestones and entrustable professional activities that you just heard about a moment ago. And we have to recognize that while assessment drives learning, learning should also drive the right kind of assessment. And again, this has to occur in a high-functioning clinical learning environment. That's what the CLE stands for inside the box. Let me end with talking about another mechanism to help us get there. It's called co-production. This is from wonderful work by Paul and Maren Batalden. We have to recognize that healthcare and medical education are about providing a service, not making products. I don't like referring to our learners as products. They're health professionals that when they graduate will enter a system to provide service. And two parties are always involved in making a service. Again, think about the wonderful example we just saw from shared decision making. It takes two to engage in that activity. And services, when they're done well, are always co-produced. And so from an educational perspective, this is a nice graphic from Bob Englander and colleagues, building on the co-production work in clinical care from Maren Batalden, where learners with teachers are partners in a non-hierarchical relationship where they co-execute, co-plan through civil discourse to produce high-value learning for healthcare professionals and patients so that everybody wins. That one of the dividends of high quality, effective education is in fact better patient care. And there's evidence that when that happens, that's in fact what occurs. And so providers and patients who co-produce healthcare is the ultimate goal. This is embedded within the healthcare professions education system. You heard about several hospitals and some of the unique work that's going on, such as Woodlands in Singapore and the hospitals there in Taiwan. And obviously, community and society plays a major role in shaping the educational process. We can also think about co-production as an iterative ongoing cycle with our learners. If we start at the bottom, we co-design the plan, in this case, the educational plan, to fit the learner and program's goals, context, and capabilities. And you design the educational interventions to maximize the outcomes, as we talked about earlier. Once that plan has been designed, such as an individualized learning plan, you co-deliver it and ask yourself, how can the learner contribute? And then what can the medical educator or team do to support that learner? And then after you've delivered the intervention or the curriculum, whatever it may be, you assess together with the learner. Where do we stand? Were the previous educational interventions effective? Do we need to change things? And finally, you co-decide on what the next steps are based on the learner's goals and the needs of the program. And you compare options to make informed, preference-based educational choices. You may recognize this looks a lot like a plan, do, study, act cycle, and it does. Or it looks like Kolb's educational cycle. Education, professional development is an iterative cyclic process. And we need to think about that more through a co-production lens and do it with our learners instead of to them. And so the learners' roles in this process are as follows. They have to learn reflective practice and self-regulating learning skills. They have to adopt a growth mindset. In other words, be willing to learn from failure, be able to recognize limitations and weaknesses, but work on them. They have to engage in informed self-assessment and reflective with faculty and peers. They should actively contribute to a learning portfolio, whatever that looks like in your particular context. And then be able to create individualized learning plans in partnership. That's that co-production process and that cycle I just showed you with faculty and other team members in the educational space. And always be willing to seek input from interprofessional team members and patients. Ask patients, how do you think that went? One of the simple questions we used to ask at the end of clinic of a visit with a patient was, did you get what you needed today? Simple question to end the visit. And then we'd have a conversation to make sure that that's what had happened. Same thing we need to do in education. And so transforming medical education, which I think the pandemic has put greater pressure on for us to do, will require explicit and dedicated attention to diversity, equity, and inclusion in both clinical care and education, and that should be seen as a synergistic, integrated activity. We need to embrace all 5 core components of an outcomes-based education approach and recognize that when we are training health professionals, it is an intensely developmental process. We need to rethink educational design with better integration of our curriculum and assessment, such as where we have people training and what they're being trained to do. We need greater engagement to learners as active agents, but do that through a co-production process. And finally, we need to embrace implementation science to guide transformation, because you also heard there are new skills on the horizon and some that have had to accelerate already, such as telehealth, telemedicine, augmented intelligence. That's not going away. That's only going to accelerate. We have to be able to adapt to medical education to better prepare future health professionals to work in all those new fields. And so I'm going to come off stop share and thank you for having me. I understand there'll be questions at the end, but thanks again for having me.
Thanks, Dr. Eric, for the impressive speech. And the last speaker will be Professor Jeffrey Braithwaite.
Jeffrey, are you online?
I am indeed, thank you.
Okay, now it's your turn. Let's welcome Professor Jeffrey.
Thank you so much. And I'm now sharing my slides. Okay?
Okay, let's begin. Thank you.
Thank you very much. Thank you very much, Dr. Hu-Ping Liu, for moderating and the fantastic talks that have happened in this session from Dr. Hong Jun Lin who spoke on hospital sustainability, and my friend, the president of the Joint Commission of Taiwan, Dr. Jiang Lin, and also Dr. Eric Hombo from the US. And now I'd like to change the pace a little bit to stay with health sustainability and hope to add to these excellent talks that already took place to talk about healthcare sustainability. So we've heard talks on hospital sustainability and quality and safety from the Joint Commission and health professions and medical education. But now let's talk about healthcare sustainability. So I'm from the Australian Institute of Health Innovation. I'm also president of ISQA, so it is always a pleasure working with my Taiwanese colleagues in the Taiwan health system. But I'm from the Australian Institute of Health Innovation, a large group that does health systems research, including with the Joint Commission in Taiwan. So we spend our time doing this: heal, learn, discover. I spend most of my time in discovery and learning and teaching, but the goal is for all of us to do more and be better at healing. So let's talk about sustainable healthcare, firstly from a global perspective. Let me ask you this question: is this system sustainable? Is the Taiwanese health system, as I understand it, and I'm a regular visitor to Taiwan, and sorry I can't be here today. Here's the Taiwanese health system at a glance: 24 million population. Almost 1 in 6 of the population is age 65 and over. The number of physicians per population and nurses and beds per population, a system funded from more than 3,000 US per capita, per person, and delivering life expectancy at birth of over 80 years. By anyone's measure, this is a successful system, one that delivers well for the population and is not very expensive compared to many health systems, especially, Eric, the US health system, in the world. So at a glance, this health system is doing well. But the question is it built to last across into the future? And that's what I'd like to tackle. Before I do that, let's talk a little bit from a global perspective and try and situate the Taiwanese health system in a global perspective. So a couple of years ago, 3 famous reports, yes, I agree, Dr. Holmboes has said to me the US is one of the most expensive systems in the world, and therefore it's good for the rest of us to benchmark against the US health system on the basis of cost, Eric, because we all look good. So in 2018, 3 reports hit the world at once, simultaneously in the same year. And this was very interesting. Those of us who study science know that sometimes a time is clump and things happen simultaneously in science all at once. The idea has currency. And in this case, 3 major reports occurred all at once from 3 different bodies, crossing the global quality chasm from the US National Academies. The Lancet Health Commission published a study on every health system in the world, looking at how each was going according to the WHO's Sustainable Development Goals. The UN and WHO's, how are we doing with sustainable development of health systems? And then the WHO, OECD, and the World Bank published Delivering Quality Health Services. What was interesting about this, and here's my brief summary of each of these, just for completeness, but you can read these, or if you don't have time, the executive summaries, they all said something similar, that we need to improve the quality of care across the world, and that we need to implement research-based, evidence-based evidence into practice, so that quality of care was uniformly very good, that we needed to look at how we were tracking compared to each health system, and identify and spur on evidence-based to improve health systems. So these reports, interestingly, came from very different directions, but all said something similar. That we need to make a concerted effort to provide systems-based evidence approaches underpinned by research to better quality of care and more equitable care within countries and across countries. So this was a global call to, and so I published a paper on this with colleagues saying, what should we do with all of this? And what we concluded, myself and colleagues from across the world, was that we needed to have each country have a blueprint towards the future, say across the next 10 years. We needed to tackle quality of care, but also equitable distribution of care within every country and across countries. And we needed to put money where it most mattered, to those people who aren't getting good health care, actually deserve it. And Eric Holmboe talked very persuasively about inequities in the US, but every health system has inequities. So here's a synthesis of the three reports in a word cloud. You can read the paper, it's quite a short one in BMC Medicine. Here's the main topics, the themes and contexts. These reports were about health and care and a systems approach to quality. There were various countries, they canvassed every country. There's lots of global ideas and studies in this array of three reports. And so the question is, if 2018 is the year of analysis and reports, can the 2020s be the decade of concerted action across the world? Well, one of the things that happened, which every speaker has posed, is that a pandemic intervened and perhaps slowed down, because everybody had to tackle the pandemic, COVID-19, perhaps slowed down the impetus on refreshing the quality of care and improving patient safety across the world. So it's time, when the pandemic begins to end, it's the beginning of the end of the pandemic, we hope, to move on to having a look again at quality of care and patient safety. So how do we do that? Well, in some other work, we've been looking at all the key performance indicators that health care systems produce to try and track care across time. And most health systems have many, many key performance indicators, targets, and goals to meet. So we looked at the literature on this and concluded that really, if we had three main targets, we could run better healthcare. And this runs alongside these three big reports. So we published a paper on this a year or so back in BMC Medicine and called this the 60-30-10 challenge. Because you see, it's now well known that about 60% of care, on average, across common conditions, is in line with level 1 evidence or consensus-based guidelines. About 30% of care, this is usually mostly US data, but I think it applies to many health systems. 30% of care is wasteful. Care that shouldn't be delivered, servicing, tests that never get seen, administrative burden that could be reduced, then the money spent on care rather than administration. There's lots of wastefulness in health systems. And then 10% is the ongoing rate of adverse events, of harm, some of which leads to serious harmful consequences for patients. So 60-30-10. So what we have to do is improve the quality of care, the amount of care that's in line with evidence or guidelines, and reduce wasteful care and reduce the rate of adverse events. Now, that's easier said than done, but if we focused on these three targets and we beat them, we'd automatically have more money, less harm, and more care delivered in a quality way. What's not to like about that? So maybe we don't need all the key performance indicators and goals and targets and metrics that many health systems are pursuing. So, second last thing I want to say is a system that's sustainable, built to last, is going to serve us across the next 10 years, is one that is resilient. And just like people can be resilient, we think health systems can be resilient. So a resilient system is one which, regardless of what we do with the health system, a pandemic, a major crisis, a shortfall in funding, whatever we throw at it, it sustains its required operations under those expected and unexpected conditions. And this is from another Eric, my very good friend, Eric Holling. So resilient performance, that's a health system that's quick to respond, adaptive, and monitor the situation it finds itself in quite rapidly, has quality of care and a concerted effort to improve care for patients baked in, built into the DNA of the organization. It's one that can do workarounds and heuristics, learn how to learn, and has a capacity to improvise, be flexible, and maneuver when called on. And the best countries, the best health systems did this better than other health systems when faced with the pandemic. And I've got other research to share with you on another day, which explains this. So what we want of a health system that's sustainable is one that's resilient, that can continue to perform and perform well and bounce back when things unexpected or expected hit it, and it can still continue to perform, but also one that's reliable. So one that's flexible and one that's consistent across time. And so if there's a lesson from me for health systems from the pandemic, it's the way different health systems coped with the pandemic and maintained flexibility and consistency of effort across. Taiwan, for example, is one of the very good health systems, performed better than most during the pandemic. Final thing I want to say is I'm the series editor on a series of books on the future of healthcare. And I've published a paper summarizing some of that work recently in International Journal for Quality in Healthcare, the ISQA Journal. That is, that we have a roadmap to the future for our global progress and sustainability within systems, within healthcare systems at the country level and across. And so in that work, if I can synthesize it in only 3 slides, there seems to be 5 main trends going through health systems across the next 10 years to 2030. One is the desire for health systems to be sustainable. Another one is exploiting key things such as precision healthcare. Let's call that the genomics revolution, targeting care for patients. Emerging technologies, there's 2 different kinds. There's information and communication technologies, such as big data and the electronic medical record. And then there's clinical technologies, such as new drugs, new treatments, new diagnostic capacity. Global demographic dynamics is the 4th trend, and that's about aging populations, changing demands amongst populations for the way they see healthcare in the way that Eric talked about co-production, and Paul Batalden, another good friend of mine, talks about co-production and collaborative care, taking into account the voice of the patient. And finally, new models of care. Again, the lesson from the pandemic is how we could shift very rapidly to telemedicine, telehealth care, and provide new models of care very quickly. So, in this work, 3 books involving 152 countries, there were 9 main themes that people are working on to try and create sustainable health systems. Integration, so patients don't fall through the cracks. Having sufficient resources to fund care. Thirdly, patient-based care and empowering the patient, many of the things previous speakers talked about. Universal health coverage in every system so that all the population equitably gets care. And Sir Michael Marmot is going to talk about that in a keynote shortly. Technology and information technology is the pin, and everybody's working on this too. Aging populations, dealing with our vulnerable aging populations. Not just emphasizing acute care, but also preventative care. Putting in the right policies, accreditation standards, and policy and procedures, which JCT in Taiwan is absolutely top of the tree on, is a fantastic example. Finally, workforce, which is what the theme of this particular section is called. Health, human development, education and training. The workforce of the present becoming fit as the workforce of the future. So that's all I wanted to say. Here's a final wave. Some of my team in Sydney, Australia, which several people in JCT and also in Taiwan have visited in recent times. And when the pandemic ends, please come down under and visit us in Sydney, Australia. So thank you very much. I will stop sharing. And that is what I wanted to say to talk to you about my side of this excellent section we have, previous speakers who have spoken to us. So thank you very much for listening. Thank you, Madam Chair.
Thank you. Thank you, Jeffrey. And not very familiar with your presentation just on one side, because I miss your presentation, especially for your body language. And right now, we have the joint discussion section. I will invite the two speakers, two Dr. Lins on the table, and two professors online. I have one question from the audience. I think the question is for Eric. Because
yes, thank you. I did read this from Kenneth.
Yeah.
I'm happy to speak about the U.S. situation. You know, Kenneth, in the U.S., the situation is more fragmented than what you would see in other countries. And I see Jeffrey his head, and I'm totally with him on this. You know, we do have, interestingly, we have some consolidation, if you will, around accreditation for graduate medical education. But accreditation in each health profession is pretty separate. There's actually two different bodies that do medical students, if you will. We have 70 state licensing boards. And you're probably going, wait a minute, you have 50 states. How can you have 70 licensing boards? Well, in 20 states, the osteopathic and allopathic licensing systems are different. And so this fragmentation creates a lot of challenges for us. With regards to the pandemic, some of it did actually adapt pretty quickly, to use Jeffrey's wonderful talk on concepts, by creating relaxation of licensing standards to let physicians move across state borders to fill in for care. With regard to trainees, it varied. In the early part of the pandemic, students were pulled offline partly for safety reasons, but to be perfectly honest, in many locations, it was because of a shortage of personal protective equipment. And so there just wasn't enough to have them on the front lines. That has changed dramatically in the last year. And now students, residents are playing a major role as folks and hospitals have adapted. Most hospitals now have created COVID units so that they kind of segregate the COVID patients into a particular portion of the hospital, and that's allowed other operations to pick up again. So for students, it's varied. Some are very important in the early days of the pandemic. To our knowledge, at least one student in the United States died from COVID this past year, and we lost 4 residents in 2020. So it wasn't without a cost. Our Obviously, as you know, we've been severely impacted because of our dysfunction. We're now at about 750,000 deaths due to COVID as of this morning. So, you know, a lot of disruption, variable ability to adapt and respond. That kind of resilience piece was variable across our educational institutions. And accreditation in some places or licensing's help, but in others that fragmentation was problematic. And I'll stop there and see if anybody wants to add anything, or Jeffrey, you want to say anything from Australia?
The question is about how can we assure the quality assurance of educators, because every teaching hospital are responding for the disaster. So such as medical students are not allowed to join clinical service because the professors treating them as students and not the work colleague. That's why the audience asking about how do we assure the quality assurance of educators.
Yeah, sorry, that was the second part of that question. I apologize, I didn't address it very well. This is where I think training is critical. You know, we call it faculty development, but I think that still is really important. You always have to be upskilling the workforce, and education is no different. I think some of our educators really struggled. Part of it is they got pulled to cover for COVID care and therefore weren't even available to students and residents. But I think we have to have ways to more quickly upskill folks. I was actually in the U.S. Navy for a number of years, and interestingly, the military is better at this because they prepare for when things don't go well. I'm not so sure every institution does that as well, where when you have these sort of things, being prepared for pandemic or a mass trauma event, they're a little better, but some other natural disaster, you have to adapt, and you have to make sure you have other sets of skills available. And if you don't, you have to be able to train people pretty quickly. I don't know, Jeffrey, what are your thoughts on this? Obviously, this is a major focus of what you just talked about.
Yeah, you're answering these, Eric, very comprehensively, but I would just add that ISQA, the International Society for Quality, which JCT, for example, Taiwanese health system people come to a lot, the annual International Society for Quality Conference, has been running some crisis preparation and crisis management type workshops. And I agree with you, the military and the medical military has done this really well over the years, but it hasn't permeated healthcare sometimes as well. And I'd really like to see more training and development and thought about, you know, preparing people to be flexible and adaptive. But I think COVID has taught us a lot about this across the world, and we're yet to learn fully about the different ways people have learned how to be flexible and adaptive very quickly.
Thanks. Is there any questions from the audience on site?
Eric and Jeffrey, very nice to see you again. Although we are online, not on site, but however, I enjoy both your talks both very much. And I have two questions, one for Eric and one for Henry, because both of you have been to Taiwan for many times. You have known the recent development of the Taiwan medical system. So for Eric, you talk about the five outcomes, the core outcomes of medical education. And do we have any suggestion to Taiwan? Because you know that Taiwan is going to adopt the competent-based medical education. What do you suggest if Taiwan to adopt it? Is there any, I know that you have given us many global consensus, but however, localization of the EPAs or other outcomes would be important. Do you have any comments or suggestion for us? And for Henry's, I think you are very, very familiar with the medical system in Taiwan, and you talk about the 5 major concerns and the 9 major themes. And what do you think that Taiwan should improve in the quality improvement or other things? Of course, before you answer, I want to answer the same question. I think the cooperation between the government and the teaching hospital or universities, medical schools are very important. And the students should not be treated as only students. I believe that learning the knowledge and the clinical skills, I think the hand-on and be treated as a team of the medical, as a member of the medical team is very important. That is why Taiwan Medical Accreditation Council have been working very hard to improve, to make the students, not only students, the clerkship, it is a learning doctor. I think that will be important, and I think it is a very good question, and that is something that we have to work harder in the future. Thank you.
I think Eric will be the first one to answer Professor Lin's question.
Okay, thanks. No, I'm happy to do so. I actually think the hardest part in education is that thinking developmental kind of perspective. We tend to put folks into kind of similar models or designs and expect to get, high quality outcomes. And I think that has been problematic. The probably best example of that is the concept of using rotations, where we rotate people through these various experiences in different combinations without really thinking about where are they developmentally with regards to their competency development. I think that's a huge challenge because we're very dependent, particularly on our postgraduate trainees as part of our service workforce. And so, to be more flexible in how they train, I think, is a major issue. Another concept I'll borrow from quality comes from Jack Wenberg and his work. I think we have to take a look at what's warranted variation within medical education and what's unwarranted. And I worry that some of the variation that we've tolerated in health professions education would, be classified as unwarranted, in other words, unjustified. And I think we're going to have to take a look at that. I give Taiwan a lot of credit. One of the things I think is a real strength there is the crosstalk between professions and specialties. I think you're doing a better job of that, for example, what I see in the States. We tend to be very siloed here. Whereas in Taiwan, I'm very pleased to see this kind of integration and crosstalk sharing of, if you will, notable practices, effective practices. And I would strongly encourage you to keep doing that.
Thank you. And Jeffrey?
So, I follow what Jay's, thank you, Chi Jiangying. I mean, that was a very great question. And, we could spend the rest of the day on it, and thank you for the challenge. But if I think about JCT and I think about accreditation, human-centeredness, both ends of the scale, justice and equity, hospital and healthcare, and openness and transparency, all of which are part of your logo. And then the 5 things that JCT does looks at promoting policy, accreditation, very good operations, harmonious relationships, and quality and safety, all of which is on your website and I know very well, then you are absolutely on the right track of those 5 trends and 9 themes that I spoke about. I would only suggest that maybe you could use those as your checklist, as your benchmark to say, how well are we going across time? Because I know within the Taiwanese health system is the feeling that we will continuously improve, continuously innovate. So my sense is this is a journey, not a destination. Taiwan is in a good place, and like every health system can do better. So maybe use my points, my trends and themes as a way of benchmarking across time. But my sense is Taiwan already does very well. Thank you for the question. As always, you have challenged me yet again.
Thank you. Because of the time limit, I think our section will be closed. But before the closing, I would like, on behalf of the Ministry of Health and Welfare, thanks for 4 speakers from United States and Australia, also from Taiwan. Let's Give all the speakers applause.
Thank you.
Thank you. Keep in
me,
touch. Keep in touch because I think we learn a lot from you. Thank you. Bye-bye.
Thank you. Bye.
Ladies and gentlemen, thank you for your participation. We hope you have wonderful takeaway. Now it's time for coffee break. Please follow our staff outside for direction to the break area and return to room 1101 at 1510 for plenary session 3 of the forum.